Yeah.
It doesn't have a year on it.
Okay, cool. That's fine.
Okay, so we're now live. Hello, everyone. My name is Taha. I see one new face. Thank you, everyone, for coming, especially in your spotlight. I know it's a very, very tense and stressful period for you guys. But I hope either we're coming all here. It's going to be 2 hours of solid, well, maybe 2 hours of solid revision. I hope. It's going to be good revision. We're going to continue on from where we left last week. And we're not going to do all the side questions either, bless up, but we're going to do the ones that I flagged and I think are good for discussion regardless. Okay, so just give me 1 sec and I'll get ready. Okay, you can all see that, very good. Okay, we'll just get straight onto it. So we're starting off where we left off last week. So we left off on this question. So let's start here. So we have a 19-year-old man presents to his GP with a 2-day history of shortness of breath and exertion, a dry cough that's associated with pleuritic chest pain. He's felt generally unwell with a severe headache for several days, high temperature, chest exam is normal, okay? So you know you always do that on the words. But his X-ray shows patchy shadowing of both lower lobes. What do you think he has?
Mycoplasma.
Mycoplasma, so what would you, okay, so you choose A? That's correct. Okay, so atypical pneumonia is absolutely correct. That's how mycoplasma looks like, and the reason I put it up there is for a few specific reasons. So with atypical pneumonia, you might all, especially with mycoplasmic pneumonia, you might have heard of the term walking pneumonia. Okay, so the reason for that is that these people they are very unwell, but they're still walking. As somebody who has moderate to severe community-acquired pneumonia with a typical organism, you might expect that they would require maybe a admission to hospital or a course of antibiotics, and they'd need to be at home. Whereas these people, they're very sick, but still they seem to be fine in the community. So atypical pneumonia, importantly, we need to talk about the differences between the symptoms you get in atypical pneumonia versus the symptoms you get in atypical pneumonia. So first of all, so typical pneumonias, what are your common organisms that you have in there? Strep, what else? Yeah, what else?
Varicella.
Yeah, anything else? Yeah, got Haemophilus. Anything else?
Staphylococcus.
Sure, Staphylococcus, okay. So all of these, in general, are usually organisms that have a cell wall. That's why the treatment for typical pneumonia, as a general thing, we'll talk about the treatment soon, is something that is some sort of beta-lactamase, cephalosporin, something of that nature. Whereas an atypical organism, for example, mycoplasma, chlamydia, these kind of organisms are organisms that do not function based on if they have a cell wall or not. So the point of having a cell wall is that a cell wall contains toxins on the outside that can then go on to infect the patient and cause symptoms that way. Whereas mycoplasma, for example, if you look at the previous picture, these actually have specialized cilia, okay? So these little tails on the end. And what those tails allow these mycoplasma to do is to burrow into the respiratory epithelium and your alveoli and such, and grow in there to cause you to have symptoms. So one of the most common symptoms that you get with atypical pneumonia is a dry cough. So especially with mycoplasma, it's a paroxysmal dry cough that comes on very regularly. So compare that to atypical pneumonia, which is a productive cough. So that is why somebody that doesn't have a cough, so somebody who does not have a cough rules out atypical pneumonia in most cases. Not always, but most cases. Otherwise, it's a lot more just systemic features and very few respiratory features. So more systemic rather than respiratory. So fever, malaise, persistent, incessant cough. So that is what makes pneumonia most likely. And if you're to do investigations, what you'd see is that with a typical pneumonia, you would expect a leukocytosis, so an increase in your white cell count. Whereas with atypical, that doesn't happen, okay? The white cell count actually usually stays normal. I don't know the reason for that, but it's not a helpful predictor or a helpful investigation to do with somebody you suspect has atypical pneumonia. So labs in general are not very helpful. One thing you should remember with mycoplasma is that sometimes it can be associated with a hemolytic anemia. So one of the things that they are associated with mycoplasma was the cold agglutinins. So the cold agglutinins are the things that cause you to have this hemolytic hemolysis of your blood cells. So you might see that on your FBE, but it's not a common finding. Okay, so CAP. So this is all from ETG. And I just went through the ETG page because I have time at the moment, but you guys don't, and trying to identify all of the very important information I could. Okay, so community-acquired pneumonia defined as either something that happens in the community or within 48 hours of an admission to hospital. So antibiotic therapy is usually empirical. So what that means is that you don't have to wait for radiographic findings, you don't have to wait for labs to give them therapy, but you often still do it to establish the diagnosis regardless, which is the second option. That is important because that has been a previous question that I think we've done on the other faculty release exams, where I was asking you what the best treatment for pneumonia would have been, or a patient presenting with pneumonic symptoms. Okay, as well as other tests that you do in pneumonia. Okay, so let's do these ones first. So it says that all patients who have severe disease, and we'll define what severe is in a moment, but mostly somebody who is hemodynamically unstable or has significant symptoms, all of them need to have these 3 tests, okay? Which is a pneumococcal antigen, so to test for strep, a Legionella antigen to test for Legionella, and finally a nose and throat swab to test for influenza specifically. But a NAT, so a nucleic acid amplification test, what that can do, that can identify mycoplasma as well as chlamydia, Legionella, and other viruses, but specifically looking for influenza, okay? Last one, IgM serology, you don't always do it, but you can do it for mycoplasma specifically, so that's looking for the antibodies in your blood that will go up in relation to getting a mycoplasma infection. And then the last one is a bronchoalveolar lavage, okay? So all of these tests are things that you would do for somebody who has serious pneumonia, or when, specifically in this case, when they have all of the symptoms and they haven't responded to antibiotics, but you haven't been able to identify what the pathogen is. So in that situation, you do a bronchoalveolar lavage, where it's an invasive approach, where you're inserting fluid into the lung cavities, extracting that fluid, and then sending it off for pathological examination, okay? Then the last thing is that red flags for pneumonia. So imagine you were in an OSCE station and it was in the stem, you'd have to identify what the red flags are, and the examiner might ask you what features on this scenario are most significant for you. So respiratory rate above 30, SBP about less than 90, heart rate above 100, and oxygen below 92. So important things to know about this is that all of these would be indications for a MET call, for example. So that's why they're red flags. Anybody who has an altered mental state, because they could have neurological involvement, or it could be an organism that you haven't thought of, or if you have multilobular involvement. So in this case, anybody who has any of these, they need a clinical review, and they need to be assessed whether they need to be managed as an inpatient or not, because any of these symptoms would indicate somebody who has moderate and or severe pneumonia, and moderate or severe pneumonia always is an indication for potential inpatient management. Does that make sense? Okay, so going
real quick, I'm not going to stick around, but I just wanted to wish you guys all good luck for your 4th year exams. Enjoy your holidays afterwards. It's like the best feeling to finish everything and to
some wise words from Krishnan.
And I just want to say thank you to Taha for holding it all down, because the rest of us have been quite slack. So yeah, just give a big round of applause to Taha. And I'll see you guys next year. We'll try to help you out with, the whole references, job applications kind of crap. But until then, just good luck with your exams and enjoy your holidays. All right, guys, see you around.
Thanks, Krishnan. Thank you for coming.
All right.
Big thank you to Krishnan, who is one of our biggest supporters last year in 3rd year YESPA. So going right back to it, thank you again, Krishnan. So talking about pneumonia management. So this is directly from ETG. So this is very, very easy to remember, I feel, because it's just A, B, C, D, okay? So A, B, C plus D. No, has to be. Okay, plus D. So for mild pneumonia, so cap severity for mild pneumonia, so mild pneumonia always entails somebody who you think is well enough to go home. So they will be discharged on oral amoxicillin for 5 to 7 days. So especially for common diseases, I think it's important that you know the time course of the medications that you're giving them. You might not need to know the dosages, but at the very least 5 to 7, so a week course. And you'd also give them, and if it was an atypical organism, you'd give them doxycycline. Okay, so for all atypical organisms, you give them doxycycline. Again, because that's a macrolide, it's not a beta-lactamase sort of antibiotic that we're using for typical organisms. So moderate, you go up to pen, so IV. So the reason it's IV, because they probably require an admission to hospital, so you can give them IV medications. There are some situations where you can discharge somebody with moderate to severe pneumonia and still give them IV medications, but it's not common. So just take it as a rule of thumb. Anybody who has moderate to severe requires inpatient admission. So pen plus doxycycline. So this is also a 5 to 7 day course. And somebody who has severe, use ceftriaxone plus azithromycin. So the azithromycin might be a little bit harder to remember in this. Would be a bit harder to remember this situation, but in general, it's your A, B, C, D approach. So A, B, C, and then plus D for pretty much everything else. Okay, so 4 organisms that you have identified that have either low or high resistance. That I didn't look up enough information about this, so maybe we'll just leave that there because I can't tell you too much about it actually. Okay, so a few more important things to know just from the ETG article. I think it's important. Okay, so if somebody has mild pneumonia, okay, and they go to follow up with a GP, the GP is usually the one who's going to give you amoxicillin for mild pneumonia. If they don't improve after 48 hours, then you need to consider adding on doxycycline therapy. So that's why therapy is always A, B, C, D. So consider adding on doxycycline. The other thing is that you can only give somebody oral medication, oral therapy for pneumonia if they're willing to come back for a review. So if you're in an OSCE setting, you have to tell the patient you have pneumonia, I'm going to discharge you on medications, but this requires you to come back to see me in 2 days. Okay, because at that time we're going to see how your symptoms are. We need to consider whether we're still continuing on with these current antibiotic medications. Okay, so then for moderate CAP, you want to make sure that you investigate for what the organism is, whereas for mild, you definitely probably just treat empirically. And then you give them benpen 6 hourly. Okay, so benpen 6 hourly until they improve, and then you want to downgrade to per oral amoxicillin. Okay, so in the hospital, every 6 hours, so QID, benzyl penicillin, until the symptoms improve. So for example, that could be respiratory rate, O2 saturations, clinical picture, etc. Once they improve, you then downgrade to oral antibiotics, which I'm sure all of you have probably seen on the wards already. And then as well as that, so essentially what it is, so benpen for moderate, and then once they're good, you then go down the ladder to moderate therapy. So amoxicillin, and you also give them doxycycline. Whereas for severe, you always have to remember that somebody who has severe CAP might be someone who requires inotropic or vasopressor support. So that's why they need to come into hospital. And there's many organisms that can cause it. So KEF and azithromycin is very important. Now, the medication that you use in children is very, very different. So I would just recommend that you go through the ETG article yourself on that. Okay. Next question. So we have a 22-year-old woman known to have asthma, presents to the ED with acute shortness of breath. She has a high temperature. Her chest examination reveals polyphonic wheezes throughout the chest. What does this indicate? Asthma. So this is a likely an infective exacerbation of asthma. Okay, so community-acquired pneumonia, you might have wheezes, but it'd be more likely to be in a single localized area of your lung. Remember on the past, what we just explained was somebody who has multinodular or multilobular involvement of pneumonia is somebody who has severe pneumonia, right? So by your logic, you would assume that pneumonia is always in a central or unilateral location in your lung. So that's why it's not polyphonic and it's not all over your lung. So it's not pneumonia, so not that one, not influenza, because influenza people are very, very sick and they'd have a very significant cough. And none of these, okay? So infective exacerbation of asthma is important. If you had, we just had a question on our CKT, so our clinical knowledge test, and it was a young 15-month-old child, and they were playing with their siblings, young siblings, and they're playing like chasey or something, and then he runs off suddenly, and then he suddenly starts coughing and wheezing. And then when you go to examine him, you notice that he has wheezes on the right side of his chest. And I was asking you, what is the best management in that situation? So some of the options were inhale SABA for asthma, a course of corticosteroids, antibiotics, reassurement, or bronchoscopy. So what would you choose? Bronchoscopy, why? Yeah, so that's what the question was alluding to. So especially on the right side of the lung, that bronchi being larger and at a more 90-degree angle than the left bronchus, is increased likelihood that you're going to have a blockage there than you would have in the left bronchus. So bronchoscopy was the answer. Okay, so I've put that picture there in myself. But we have a 28-year-old. She presents to chest clinic with a 6-month history of shortness of breath on exertion, so shortness of breath on exertion. She has a painful nodular rash on her shins, which is called erythema nodosum, which we can see here. And her serum ACE is raised as well as the ESR. What do you think this is? This is definitely sarcoid, okay? So sarcoid. So sarcoid is an abnormal collection of inflammatory cells, abnormal collection. And what do we call an abnormal collection of inflammatory cells? A granuloma, okay? So this forms non-caseating granulomas in the lung. So non-caseating means that it's not necrotic, so it's not breaking down, non-caseating granulomas. And there's not many things that cause you to have non-caseating granulomas in your lungs. So specifically, what's important about these is that this releases the ACE. So that's what releases that angiotensin converting enzyme, which is why it's elevated in somebody with sarcoid. Now, these patients also present with another electrolyte abnormality. What do people know what it is?
Hypercalcemia.
Yeah, hypercalcemia, okay? So what happens there is that the hypercalcemia is present within those macrophages that are located within the granulomas, and that, then what happens? It's either calcium or vitamin D, which is present within those macrophages within the granulomas that increase the conversion, there's calcium or something. So it increases the conversion of vitamin D to its active form, okay? So whatever macrophages are present within those granulomas somehow cause that change to an active form of vitamin D. So you have increased calcium absorption, so you can present with hypercalcemia. So just quickly, so this picture on the right, so this is erythema nodosum. So does anybody know what the pathology actually is in erythema nodosum? Roland? Do you know what the pathology is in erythema nodosum? It is. What do you know what that means? Yes, that's correct. So a paniculitis is exactly correct, an inflammation of fatty tissue. Okay, so a paniculus, so not a paniculitis, a paniculus is just a form of a pannus. Okay, have you guys heard of the word pannus before? So pannus is what you don't want to see, but it's like your person that has these very big, large fat rolls. So that's what you call a pannus, or a large collection of fat. So a paniculus is a form of pannus, which is a very dense form of fatty tissue that that in this case has become inflamed. So a paniculitis is much more common in females than males. It's actually a 6-to-1 predominance. Okay, so it's not specific to sarcoid. Okay, because it can occur with lots of things. So specifically throat infections. So people who get streptococcal infections, they might also present with erythema nodosum. People who have TB, people who are pregnant. Okay, so therefore, if somebody's presenting like this, what's one test that you say we need to do? So ASOT, okay, so yeah, sure. But one, so ASOT, we might do, an immunoglobulin, what's it called? Mentor. No, quantiferon gold is, what's the medical name?
Immunoarray.
I can't remember, I'll remember soon. Okay, anyway, so what I was trying to get is ASOT, okay? So somebody who has had a strep throat, they can present with erythema nodosum at some point during that stage. So that's important to do. Okay, our next question. So a few weeks after starting this medicine, this patient notices that her mouth is sore and red with soft white patches on the tongue and pharynx which are easily dislodged. So what are these referring to? Yes, candida or plaques. So what medication likely caused this? Which one is it?
A.
Yeah, fluticasone. So fluticasone is your inhaled corticosteroid, okay? So as we know, one of the risk factors, something that we always tell our patients to do in the explanation section, is always rinse out your mouth with a preventer or anything that contains inhaled corticosteroids, okay? Because it can form candida, because it suppresses the immunal flora inside of your mouth. Okay, now we have a 17-year-old asthmatic who's presented to the GP with inability to write as a result of severe hand tremor. Salbutamol, okay? So this is actually the most common side effect that's listed on AMH, is a tremor. So it's a common side effect, so something you should know about. And therefore, contraindications or relative contraindications to using salbutamol are things like hypothyroidism, okay? Because you can have a hypermetabolic state, you can have a tremor there. Myocardial insufficiency, because it can speed up your heart rate, myocardial insufficiency. Okay, so anybody who has ischemic type chest pain, some arrhythmias, etc. Okay, so important to know. Okay, so the asthma handbook is actually a bit difficult to read just because there's so much in there, as well as so many footnotes. But because asthma is such an important topic for GP, for a potential OSCE station, for even a PET station, it's really important that you go through it. So I went through the quick reference guide and I just picked out some specific pearls from it to help us remind of some things that we've learned so far. So specifically to asthma investigations, you want to do your FEV1 before and after the bronchodilator, because what are you trying to look for? You're trying to look for this 12% increase as well as this 200 ml increase after administering the bronchodilator. So we probably remember that from our year 2 VIA days. Otherwise, they can have a decreased FEV1 over FVC. That's not normal for their age. A diagnosis of asthma should not be made if the cough is the only or predominant respiratory symptom, okay? And there are no signs of airflow limitation. So in that case, if they're only presenting with a cough, think of other diagnoses before you think of asthma, okay? This one is important. So anybody who's experienced a flare-up of any sort, or if they experience nighttime waking, so asthma symptoms at nighttime that cause them to wake up, all of these patients need to be put on a regular preventive treatment, which we'll look on at the next page. And then this one, factors associated with increasing risk of life-threatening asthma, so things that can cause you to die. You might get this as an auscultation, who knows? So 2 or more hospitalizations, if you go to the ED, if you use lots of your Ventolin, okay? If you have sudden onset asthma, and if you have some cardiovascular disease, okay? And then this is just a reference table for looking at normal heart rate and respiratory rates for children. Okay, so this is a good table that you can't read there, but this is differentials that you should think about for when children present with different symptoms. So for example, if they have unilateral wheeze, inhaled foreign body, so the thing that we just talked about. If they have feeding difficulties, you need to think about aspiration. So I think a good thing would be to go through this table and look at what kind of things they've identified. So for example, finger clubbing, cystic fibrosis. So it has these links there that would be good for you to know. Then I think the second last table is, this is a good table actually. So this tells you when it's important to start a preventer, okay? So if we remember how we had that question on a previous faculty release exams, where it was asking us what preventer or what next medication should we start in this patient, and they were already on several preventers, and the only other class that was left for them was multi-loop class. So this table also supports that answer, in that patient, I think it was symptomatic more than twice a month, and if that's happening, other than starting the regular ICS plus the SABA as needed, you could also consider this alternative on multi-loop class. So this little symbol actually is just about talking about PBS, so it's not really important. So all of these actually, all of these next 3 ones, all of them require you to consider putting the patient on the regular ICS. So something like fluticasone. So if you're waking due to asthma, so if you have nighttime symptoms, if you have had any flare-up of asthma, and if you've required any ICU admission. So any of these patients require you to start regular fluticasone or any kind of inhaled corticosteroid, okay? For somebody who's not taking a preventer and they have very uncontrolled symptoms, as well as the regular ICS, you can consider increasing it, and you can consider the corticosteroids. So just a good table to go through. And this is the last one. So this is for children. This actually, it's so hard to go through this and make rules for you guys, but I'm not going to go through that. I think it's better if you read it through yourself on the asthma guidelines in regards to treatment for children. Okay, so moving right along. So we have a patient who's been taking her medicine regularly for several years before she starts to complain to you about lower back pain. This back pain is increasing in severity, and thoracic spine X-ray shows crush fractures of T10 and 11. So what caused her symptoms? Oral pred. So unlike a previous question we've had on a similar topic, this one actually makes sense. So if we remember what the risk factors are for having a fracture, a hip fracture within 10 years, one of them was the regular glucocorticosteroids that you've been using more than 5 milligrams for more than 3 months. So this patient fits that criteria, so that is a very reasonable answer. The other thing is that anybody who has had a crush fracture, which is not normal, is instantly diagnosed with osteoporosis. Okay, you don't need to get a bone mineral density. You don't need any other history. If they're presenting with a crush fracture, you diagnose them with osteoporosis, and then you can treat them as such. So you can manage them, give them therapy. Okay, did I put that picture in there? I put that picture in there. Okay, actually, yeah. So the reason I put that picture in there is that these are the options, and we're going to go through each of these drugs, okay? Because I think it's very important that we go through these drugs. So starting with A, okay, acetazolamide, what is that? Anybody?
It's a carbonic anhydrase
Okay.
inhibitor. Works as a diuretic.
And what do we use it for?
So we can use it for glaucoma.
Yes.
So either in the acute setting or for a long term. It's less used for long term. We can use it for elevated ICP, so benign intracranial hypertension.
Perfect. Very good. So acetazolamide, carbonic anhydrase inhibitor, glaucoma. Okay, cyclovir ointment. What do we use that for? HSV keratitis. Okay, so that is just an antiviral. A methacaine, what do we use that for?
Local.
What does it sound like? What is a methacaine, first of all?
Sounds like a local anesthetic.
It's a local anesthetic, that is correct. So what do you think we might use it for? What kind of stem might you imagine might present with somebody who needs the methacaine?
Foreign body. That
Exactly,
needs to be
perfect.
removed.
Okay, so somebody who's presenting with a foreign body, because remember the cornea is very, very painful, is very, very innervated, very sensitive. So you can put some methacaine drops or actually, I'm not sure if it's a spray, but you can put drops that anesthetizes the eye, and then you can remove that. Okay, chloramphenicol. So that is an antibody. So that's a topical antibiotic in this case. Okay, and what do we use it for? I'll just change my color quickly. Yes, that's correct. So we use it for bacterial conjunctivitis. Okay, and you can another one that you can use is something called framicetin. This is actually one of the antibiotics that is present within those ear drops that you use for otitis, acute otitis media. Okay. Huh? Is it? Yeah, externa. Yeah.
That makes sense for me.
Acute otitis externa. What do you guys remember the name of the actual drops? Sofradex, yeah. So that has many, many medications in it. One of the medications it has in it is framicetin. Okay. So chloramphenicol, another thing that you need to know about it is that you don't use it systemically. Okay, you don't use it as a systemic antibiotic because it can cause bone marrow suppression. Okay. Ciprofloxacin. What do we use that for?
For like bacterial conjunctivitis, there's our alarm features.
Conjunctivitis.
Like, contact lens use.
So keratitis. Okay. So we use it for bacterial keratitis. Okay, because we use chloramphenicol for bacterial conjunctivitis. So this is for keratitis. So as you correctly said, so for people who are contact lens wearers, but also for anybody who has had any ocular surface injury. Okay, so an example of people who would have an ocular surface injury would be somebody who's had laser eye surgery. So in that case, they are at risk of getting bacterial keratitis, which would present with pain and increasing photophobia. So in which case you would prescribe them ciprofloxacin drops within a short period of time to decrease that risk of happening. Okay, next one, cyclopentalate.
It works to dilate the eyes.
Yes, that's correct. So this is the picture so that's why I've had this picture here. So that's what cyclopentalate does. So cyclopentalate is a muscarinic antagonist, okay? So if we remember our flight or fight response, we remember that flight is when our sympathetic system is activated, and our flight is when our parasympathetic. What am I saying?
Fight or flight.
Fight and flight are both.
Sorry, fight and flight is your sympathetic nervous system, right? Okay, and the opposite of that is your rest and digest system. So in this case, when we have a fight and flight response, our eyes dilate, and that is a adrenergic response. Okay, so a muscarinic response would be a parasympathetic nervous system, which is our rest and digest. So if we're antagonizing that, that would then cause a dilation. Okay, because your parasympathetic nervous system would want to constrict your eyes because it's rest and digest. So the two things the cyclopentalate does is, one, it causes mydriasis, that we can see here. So that's what's in the picture here, mydriasis. But the second one it causes is something called cycloplegia. Okay, has anybody heard of this word? So cycloplegia just refers to paralysis of the ciliary muscles of the eye. So remember, the ciliary muscles are what are connected to the lens, and if we cause paralysis of the lens muscles, that prevents us from having an accommodation reflex, an accommodation response. So because the ciliary muscles can't change the convexature of the lens, we can no longer be able to accommodate properly. So you can use it in the treatment of uveitis. Okay, so that's usually where we use it, because uveitis can present with a small fixed pupil. So you can use cyclopentalate in that case. I'm not sure where the accommodation part of it comes in. Okay, dexamethasone, where would we use that? We know what that is, that's a steroid. And where would we use it?
Use it for anterior uveitis, but you prefer to opt-out for that.
That's great. And other things we can use it for allergy, and we can use it for injury to the cornea, so corneal injury, for things that are caused by like chemical or heat burn that would cause inflammation. So we can use dexamethasone in those cases. Lantaprost. Does anybody know what lantaprost is?
Prostaglandin antagonist?
It's an analog, okay? So lantaprost is a prostaglandin F2 alpha analog, okay? Analog. So that increases the scleral permeability. So it increases scleral permeability. So that's why it's also used in glaucoma to try and increase that aqueous outflow. And it's usually used for the chronic management rather than the chronic setting. So usually chronic. So then pilocarpine, what's that used for? So this is a miotic agent, okay? So this is for glaucoma and it causes constriction, okay? So it causes a constriction of the eye, which is really important in the acute setting actually. What's olopatadine? It's a prescription antihistamine, okay? So when he came to Australia at the time, there wasn't actually that many antihistamine drops that were available on the market, which is why I believe they must have put it on the paper for that reason. Okay, timoptilol. What's that? So that's a non-selective beta blocker. So non-selective beta blocker. And what is this used for? Also used for glaucoma. Okay. So natural tears are just what you can get, over the counter when you ask for tear drops. So that's just for people who are having, symptomatic eye symptoms that might not actually be too serious. So moving on to the questions themselves. So this is the picture, and we have a 29-year-old man. He has an inflamed left eye for 3 days. He may think that he got something in his eye as it is quite uncomfortable. There is no discharge, but there is some watering of the eye, so we could probably rule out conjunctivitis with that. On the examination, visual acuity is normal. Examination of the eye, including eversion, does not reveal any foreign body. Fluorescent staining of the cornea is negative, so it doesn't have a foreign body. Examination reveals conjunctival injection as indicated in the photo. I mean, that's really minimal. I mean, if we look at our own eyes, we probably have more injection than that at the moment. So that's pretty normal. So somebody who's presenting with some symptoms of some eye discomfort, what do we use to help that? Tears, okay? So natural tears. So your normal things, you go to the chemist for, you ask them, can I have some eye drops? This is what they would give you. So potentially a diagnosis here could be episcleritis, okay? It's hard, but even if it was episcleritis, the management wouldn't change. You still give them natural tears for symptomatic relief, and you might prescribe them some NSAIDs. Okay, next one. So we have a 52-year-old woman, a very sore right eye, progressively worse over 3 days, watering, no discharge. She thinks it's a bit blurred. There is a marked conjunctival injection in the right eye, so it's unilateral, and you can see that it's decreased her visual acuity. Fluorescent staining shows this pattern when viewed with a Wood's light. So what do we call this pattern? This is a dendritic ulcer, and what did this patient have? So what? B. Okay, cyclovia, that's correct. So she has HSV keratitis. So I just thought this was important to put down because we had an OSCE station last year on where a patient was presenting with keratitis. And it was a very difficult station, actually. I can't remember exactly what made it so difficult, but it was hard regardless. So I just thought it's important for us to understand what keratitis is because I didn't really know. So I thought I'll tell you guys. So keratitis, a painful inflammation of the cornea. Okay, so the outer part of the eye. And it's associated with visual loss that can lead to blindness. That's why it's a very, very important thing to identify and manage. Photophobia and red eye. Okay, so there are many different classification systems when we're talking about keratitis. You can classify it based on environmental exposure. You can classify it based on chronicity. And you can also classify it based on what type of infection you've got. So in this case, there's two types of infections, viral or bacterial, but there's also fungal, there's also parasitic, and there's also, is there another class left? Fungal, parasitic. At the very least, fungal and parasitic as well. Okay, so viral, dendritic corneal ulcer are fluorescent staining under cobalt blue illumination. So either caused by HSV or H0. So H0 is herpes zoster ophthalmicus, so essentially shingles. So herpes zoster ophthalmicus can also cause you to have a keratitis that is due to a viral cause. And it's broken down into two types, okay? So it can either be a stromal type or it can either be an epithelial type. And stromal type is worse and it requires immediate referral because it can result in blindness much more quickly than the epithelial type keratitis can, okay? You can imagine why epithelial is on your outer layer, whereas your stroma is your connective tissue and your supportive cells that are underneath, okay? Compare that to bacterial then, is typically secondary to an injury or contact lenses. So contact lenses is actually implicated in somewhere like 30% of people who present with a bacterial conjunctivitis. So usually S. aureus, but it can be in other things. So Pseudomonas aeruginosa, okay, is what is most common in people who wear contact lenses. So the reason that's important and the reason this patient is presenting like this, that's not actually bacterial, is because people who have contact lenses, their organism like is a Pseudomonas, and Pseudomonas has an enzyme that digests the cornea, which is why it can result in irreversible eye damage, and that can happen within 48 hours. So you need to immediately identify it and manage it. So this picture, what you can see is like white spotting or this opacity over the cornea is actually due to amoeba. So there's many different things, so many different infective causes, as well as other environmental causes of keratitis, but the infective ones are important for you guys to know. So okay, and I actually got written down 19 to 42% of contact lens wearers, so very high. All right, so management. So if it's infective, a cyclovir topical for 5 days, 5 times a day for 14 days. So 2 weeks of treatment. And this is how you'd look really, really, really good if you had this station again in your GP exams. So 5 times a day for 2 weeks. And then if they keep getting recurrent symptoms, then you can prescribe them a long-term oral acyclovir. Okay, another point, and I feel like potentially this might have come up this might have been one of the things that was in the OSCE session last year, because she was on some type of drops, but I can't remember what drops she was taking, and she kept telling us that she kept getting these symptoms, is you want to avoid steroids at all costs. So this isn't definitively proved, but there is suggestion that if you use steroids in somebody who has HSV keratitis, it results in significant worsening of the ulcer that results in something called an either amoeboid or geographical ulcer. So instead of it being a dendritic ulcer, it becomes geographic because it looks like a world or a country or a continent. And the geographic ulcer is what you can see down here, and you can see how instead of being in that small location, it's going all over the eye. Okay, bacterial. So ciprofloxacin, because it's such a serious problem, you want to give it every 15 minutes for 6 hours, then hourly for 2 days, and then every 4 hours until healed. So just by reading how often you need to give the drops, you can imagine how serious of a condition bacterial keratitis is. Any questions? No, I wish I'd done that last year instead of doing that this year. Okay, so we have a 23-year-old woman has been suffering from a very itchy, inflamed eye for 2 weeks. Both eyes are watering excessively. Visual acuity is normal in both eyes. Eyelid eversion is clear, and fluorescent staining is negative. Torch examination, you have edema of both conjunctiva visible, but is particularly evident in the left eye, so you can see here. So what you can see here, you can see particularly inflammation. So you can see edema of the corneal tissue and or probably what is the lid, or the conjunctival tissue. So this patient has likely a allergic conjunctivitis. So just by process of elimination, what is the only medication that would be reasonable to use? Olopatadine. So that's why if this question came up in your exam, let's say last year, and many of us didn't know what olopatadine was, because it's not something that's listed on ETG. The way that you would have got to it is by process of elimination, by being able to identify all of the other drugs that were on the list, because those are all common drugs that we should know. So that's how you would have got to the answer. Okay, so we have a 35-year-old woman. She presents after returning from a trip to the Middle East. She's asymptomatic, but is worried about a disease that she has been told about that is contracted after swimming in fresh water that can cause bladder cancer in the future. Does anybody know this is referring to? Schistosomiasis, that's correct, okay? So schistosomiasis, have I got a picture? No, I haven't. But I haven't. So schistosomiasis is a parasitic flatworm, okay? It's actually a very, very interesting condition. So what this does is that sometimes it can go up your urethral tract and it can infect the bladder and can cause bleeding. Actually, back in the day, like in the ancient history, it actually used to cause something that was termed the male period, okay? So for example, in the Egyptian times especially, boys would be considered to come of age when they would get the male version of a period, which would mean that they would be bleeding from the urethral tract. And that would be because of schistosomiasis. So it's actually really interesting. So another name for schistosomiasis is snail fever. Have you guys ever heard of that? So the reason it's called snail fever is because that parasite, so the parasitic flatworm, is released from freshwater snails, okay? As well as being released from some fish, and that's why it's called snail fever. So what kind of symptoms would you get? Abdominal pain, diarrhea, hematochezia, hematuria, and the complication that we're worried about is bladder cancer. So what you see in this picture, can anybody tell me what the pathology is in this picture?
Calcification of the bladder.
Calcification, okay. So what you see here is you can see, can you appreciate that there's that opacity? So that opacity is calcification of the bladder. So that is another complication that you can get with schistosomiasis. Okay. Now, just a few other things that I want to look at in this list, just because we might not know what they are. So dengue, do people know what dengue is? So dengue, so what kind of symptoms would you get?
Severe back pain.
So this is why it's called, what's the clinical name? Break back disease, because they get terrible pain. Break back disease, okay? So another thing that you get these very high spiking fevers, up to, for example, 39 degrees. You get this retroorbital pain behind your eyes. And importantly, something that came up on the Moodle exams, maybe you guys have done, is that when talking about the rash that you get with dengue, is called a confluent. It's islands, or so it's a confluent maculopapular rash that begins in the face with islands of sparing. Okay, so begins in the face, then I believe it begins in the face, and then so it's a confluent rash, which means that it all comes together. Maculopapular, but it has these small patches that don't have any rash inside of them, so the islands of sparing. So that's how you describe the dengue rash. And the last one that I want to talk about is strongyloides, which we'll have a look at here. So I actually saw strongyloides myself. I didn't see the patient, but I saw it at Alfred when I was in third year. I saw it in the pathology section. We actually, because we were having pathology tutorials, how you get in third year, and a path tutor said, guys, come on, we all have to go down to pathology because they saw strongyloides, because it's very rare. It's very, very uncommon for somebody to have it in Australia. So the biggest reason that you get it would be a return traveler. So a return traveler who's presenting strongyloides. So again, this is another human. Sorry, I'll use a different color. So this is a human parasitic roundworm. Okay. In some countries, not Australia, it's also called tapeworm. But in Australia, tapeworm means something different. So what strongyloides does is that it lives in the So if you have your small bowel, so if you have your stomach here, and then you have your small bowel. So what strongyloides does is that it forms tunnels and then it lives in your small intestine. So that is why you can get a lot of GI symptoms. So the GI symptoms that you get abdominal pain, you get diarrhea, you get loss of weight, okay? But the biggest symptoms and the biggest giveaway for somebody who has strongyloides is dermatological manifestations, okay? So dermatological, I don't know exactly what the dermatological manifestations are, but if you have a stem and the patient has these skin symptoms, then think about strongyloides, especially if they're coming from a developed country. Now, the reason that it's uncommon in Australia is because the way that it's transmitted, so the transmission is through your fecal soil route, okay? Fecal soil or fecal water route, which, as you can imagine, is uncommon in Australia. People don't usually take a poop on the dirt outside. So that's why it's more common in other countries. Now, the management, so what is the management for any kind of parasite? A management? Ivermectin, okay. So ivermectin is important for you guys to know, just because we did it in second year. Remember, second year pharmacology, we talked about medications that either cause paralysis or the other mechanism for parasites. So ivermectin is one of those medications. Okay. So a 26-year-old Chinese exchange student presents with fever, night sweats, cough, and weight loss. All of that indicate that she might have TB, right? So in this case, what are you going to do? Okay, so we have chest X-ray as an option. So other things that people might consider is Mantra or quantiferon. So how do we choose between them?
Whether it's acute or latent.
What do you think, Jess? I highly value your opinion.
Chest X-ray.
How about you, Psych? Good. Okay. So chest X-ray is absolutely correct. That is the answer. So I'll actually go to. Oh, I haven't got it there. So let's talk about, before we do anything. I may as well go through this. So this is from RACGP. So this talks about what you need to do when you're considering TB. So do they have symptoms? This patient did have symptoms. Are they active symptoms? They were symptoms. In which case you need to do a chest X-ray, plus you need to do microscopy, because that is the only way you can diagnose acute tuberculosis. The reason is that the latent tests are so your Mantoux and your quantiferon is for latent TB. So we have two things. We have Mantoux over here, and we have, I remember now, interferon gamma assay. So that's what quantiferon is, interferon gamma assay. So Mantoux first. So does anybody know how Mantoux works or what we look for?
So we inject some of the tuberculin protein, and then the body, if it has been exposed to TB in the past, then it'll form a reaction and you'll get a raised lump.
That's correct. Okay.
And then depending on the size of the lump, that can mean different things.
Yes, okay, exactly. So as I've drawn here, so we can first give an intradermal injection, okay? Injection of the tuberculin toxin, okay? Oh, sorry, tuberculin protein. And then 48 to 72 hours later, we come back and we look at how big is the rash. So the diameter of how big the rash is a semi-quantitative assessment of the likelihood of having latent TB infection. So that's what the MAN2 test is. So the interferon gamma is a little bit different because what this relies on is a test tube. So this assumes that a human lymphocyte, so a white blood cell of some sort, has the ability to live in the test tube, first of all, and that if that white blood cell has ever seen TB before, okay, that it will produce detectable amounts of something called gamma interferon, okay? So if this has ever seen TB before, it produces gamma interferon, which is why it's the gamma interferon assay. So a positive assay indicates that the patient's immune system, so the immune system recognizes so it recognizes TB antigens. So a TB antigen could either be from a current infection or a past infection. So you still don't know whether it's acute or not. So they don't diagnose active TB, which is why you need a sputum culture, a sputum microscopy to look for your TB organisms. So in a child where you might not be able to get a sputum sample, you can actually do a gastric aspiration because that's a useful surrogate in those people. Or if that's, or maybe before that, you can give them nebulized hypertonic saline, which can induce sputum secretions, and then you can take that. Okay. It's very rare that you'd ever need something like a bronchoscopy. So does that make sense? Interferon gamma MAN2 latent, chest X-ray for active, especially because he's presenting with chest symptoms. So he definitely has active TB, likely pulmonary TB. So this picture here. So this is your gross pathology, and then this one is your pretty pathology. Okay. So gross pathology. So what this is showing is that, look, so put your gaze to here. So this is what we call severe cavitation. So cavitation is not common for somebody to have in the acute setting, especially with a primary TB infection, but it can happen with a post-primary or a secondary TB infection. So if we revise a little bit, we remember that TB infection is broken down into several types. So primary, you can have post-primary, or you can have secondary. So primary infection is just patchy areas of consolidation. Cavitation is very uncommon, so you could just get consolidation. Okay. You might have a caseating granuloma, which is called a tuberculoma, and if that calcifies, you might see a gone lesion. So that's something that you might also see. So you might see a gone focus. So gone focus is just a calcified tuberculoma, and tuberculoma is just a caseating granuloma. Okay, so caseating means that it's not necrotic. So then post-primary infections usually occur in the upper zones. So in the upper zones of the airway, which is what you can see here, that's happening in the upper zones. So upper zones, and then this is usually either a reactive, so this is typically a reactivation TB for whatever reason or not. And then this one is very likely to cavitate. So a high percentage of patients have cavitation. So this picture is likely post-primary because they have cavitation. Sorry, not secondary, but miliary. Have you guys heard of miliary? So miliary TB is just TB that is evenly distributed between both lungs. So it looks very even when you look at a CT scan. It's all over it's a complete dissemination across the lung fields. And that's usually from a hematogenous TB infection. So hematogenous. So what you can see on this CT scan here is that this lung on our right side looks relatively normal. But then if you look here, you can see these cavities of empty space. So that would be a cavity that's forming in TB. Okay, next question. We have a 35-year-old. Okay, 35-year-old. He's a minor. He works in Papua New Guinea and he has fever of 7 days. What do you think he has? I mean, they don't really give you much in the stem, but they do give you an endemic area and they give you one characteristic feature, which is malaria. So what would you do? Thick and thin blood films. So that's correct. So malaria, so if we talk about malaria, the fact that it's in Papua New Guinea is an endemic area, number one. and the fact that he's presenting with a long-standing fever.
Yeah, but you want to rule out malaria first.
Because malaria is something that can kill. So that's actually a very, very good point that you bring up. So of things that can kill the patient, there's malaria, there's dengue, and there's typhoid. Okay, but the speed at which it kills you is different. Okay, so unidentified malaria, especially if severe, can kill you within 24 hours. Dengue, if unidentified, can kill you within 24 to 48 hours or a few days at the very least. Typhoid, if unidentified, could probably kill you within a week. So malaria is much more likely to kill you. So that's a very reasonable thing in that why we do malaria first. So malaria causes you to have cycling, spiking, pyrexia. So that is very classical. So that means cycling, spiking, increased temperature. So if we looked at a graph, this is sort of how the temperature charts would look, is that you go very high. So for example, 39 degrees and then come down to like normal, 37 degrees potentially. So that's what you would see in malaria. So does anybody know what these thick and thin blood films refer to? What is thick? So if we had a slide, right, it would sort of look like that. So all of our blood would be smeared on the slide, whereas thin, it would be less thick. Okay, there's a reason for that. So it's thick because we have mechanical lysis. Okay, we have mechanical lysis of our red blood cells. And the reason for that is because this allows quick identification if there's parasites present in the blood at all. Because if it's a thin blood film and the red blood cells have not been broken down, you need to look inside each of the red blood cells to identify whether there's parasites located within them or not. Okay, so this one just allows diagnosis and identification with a large quantity of blood, and that it just estimates if the parasite is present and how much is present. So for diagnosis. Whereas a thin blood film, it maintains the RBC integrity. So you can see the proper RBCs like this. So what we do that for is we can see the parasites inside of the red blood cell because remember it's an intracellular pathogen, and then we can identify what their pathogen load is, and then we can change what our management would be, because depending on how high the parasite load is, they have increased risk of getting neurological symptoms and dying. Yeah, but well, yeah, that's true. So you can look for subtype, but it's also for identifying how much parasitic load as well. Okay. Any other questions? You look very dead, Jess. Okay. A 66-year-old male, 66, presents to the ED or presents as an emergency to his GP. So whilst eating at a local restaurant, he experienced sudden onset of abdo pain. Whilst in the GP, he describes having pain in his lower back, abdomen and groin, and a bruise is visible on one flank, but he has no history of trauma. What's that called? That is Gray Turner sign. So Gray Turner sign is not perfect, and it's also not very common. But what is it usually very specific for? Retroperitoneal hemorrhage. Okay, and a retroperitoneal hemorrhage usually implies what?
Bad things.
Okay, it's specific.
Either ruptured AAA or pancreatitis.
Pancreatitis.
Yes, very good. So specifically in regards to pancreatitis, it refers to severe necrotizing pancreatitis, something that is going to bleed into the retroperitoneal space. So it's very, very important. Okay, so therefore, given that he has a severe form of pancreatitis, retroperitoneal bleed that could cause him to die, what does he need to do? He needs to go to the ED emergent very, very quickly, especially because it's very likely to be a pancreatitis, but it could also be a AAA. And if it's a AAA, he might have minutes to hours to live, depending on how severe it is. Does that make sense? Any questions? Okay. So a 73-year-old female complains of vaginal dryness and slight dysuria. She has no fever, sweats, or abdo pain. Urine testing is negative for all constituents other than the trace of leukocytes, so she has a little bit of positive white blood cells. She's taking Uro, which is just an alkalizer, which is some people can use as a preventative therapy, and report some slight improvement. So what do you think she needs? So I'll just tell you, so there's two options here, right? We have get a UMCS, but either treat her empirically, or we can treat her later. So what would you choose? Either treat empirically or later? Which one?
Treat later.
Why is that?
Well, she has a very convincing history that she has a UTI. She might, but she also might not.
Okay, so I'm not. So K, that is true. So K is the answer. The best thing that I can give you is what is present from RICGP, because I'm not really sure what kind of clinical pearls to give you in this situation. But what it does tell us from RACGP, from the AFB, it tells us that empirical antibiotics are justified if the symptoms are present with a positive urinary dipstick. So she doesn't have a positive dipstick. She only has mild trace of leukocytes that is not positive. Okay. It is advisable that MSU specimen be sent for MCS to ensure appropriate empirical therapy. So if they have symptoms, which she has few, she needs to have a positive dipstick first before we can consider giving her empirical therapy. So positive dipstick might include something like positive nitrates, positive glucose, not necessarily glucose, but positive proteins, plus a higher leukocyte count, whereas this one was just a trace. So you don't know whether that could be traced from something else or whether it could just be a sample that's been contaminated potentially. So that's why you'd have to wait for the MCS to come back before treating her empirically or treating her at all. Is that okay? Okay, very good. So next question, we have a 25-year-old man. He's fallen off his bike 2 hours ago. He sustained an injury to his groin. The pain has eased off significantly, but he still remains slightly tender to touch in the groin. Okay, in the groin. On the examination, you note that although his testicles are similar in size, there is a small, painless swelling in his right epididymis. So he reports that he had been aware of this for the last 2 months, but as it was pain-free, he was unconcerned and urinalysis is normal. What do you choose? Okay, so we could ultrasound him. Is there anything else anybody else would choose? So the answer here is actually G, okay? And it's not something that I can actually explain very well. I'm not too sure myself of why the answer is G. I actually emailed the person who wrote the question, and they gave me a very non-specific, very unhelpful answer that didn't help me at all, actually. But what he did mention is that he made reference to, is the question referring to the pathology being within the groin, so above the testes or below the testes? So I think what he might be referring to is the fact that this man has presented with some pain in his groin, okay, which is likely, just secondary to trauma, unlikely to be a hernia or something else. And is also presenting with this painless swelling in his right epididymis. So let's just explore this a little bit. So this pathway is from imaging pathways in the WA. So this is actually endorsed by the RACGP if you go into one of the documents. So what it tells us is that anybody who's presenting with a scrotal mass, which, I mean, it's hard to define what a scrotal mass is an epididymal cyst, which is what this probably is as a diagnosis. Is that considered a scrotal mass? I don't know. But if it was a scrotal mass, what it tells us is that, yes, you definitely want to do an ultrasound. Okay, so it tells you want to do an ultrasound. And if there is a testicular mass, then you want to do either further investigations or you want to go to an acute pathway. If it's extra testicular, so if it's epididymal, which he does in this case, you need to consider what it is. So is it a cyst? But even if it is a cyst, the first thing that came up here was an ultrasound. So it's difficult to know why. So another thing that I looked at was Androgen Australia. So Androgen Australia, Andrology Australia tells us that an experienced doctor can usually diagnose an epididymal cyst from careful genital examination, as they are separate from the testis. So from that, you could imagine that ultrasound is not necessarily the best answer based on that piece of information there. The last thing is from the big man himself. So this from who's big man? Murtagh. So it's from Murtagh's GP book. And what it tells us is that all solid scrotal lumps are malignant until proven otherwise. So therefore, he would tell us to do an ultrasound. So the question here is, do we consider an epididymal cyst a scrotal mass? The reason for that is because this painless swelling is in his right epididymis, which would be in a higher location. So it's hard to say why G is the answer. I wouldn't say it's unreasonable as the answer, but I could definitely understand why I is a good answer. So there's nothing more I can tell you about that except showing you some pictures. So this is also from Big Man's book. So it shows you how different things look. So that's the testicular tumor. So that would be a firm mass, which is why he tells us all firm mass should be ultrasounded. Swelling of the epididymis, which is separate from the testis. Okay. So if we read that separate from the testis, right? So it's not considered a scrotal and or testicular mass. So if you go back to this imaging pathway, you wouldn't need to do ultrasound. So that is the only justification that I can give you. An epididymal cyst might not be considered a testicular mass. Therefore, we don't need to do an ultrasound. Does that make sense? So that's the argument that I'm trying to make for why G might be the answer. Another thing is that hydrocele So hydrocele, just remember, unlike other things that cause a scrotal swelling, this is something that transilluminates a lot. So it's very bright with transillumination. And last thing, this is just a very good point, is that in English scrotal swelling, so something like a hernia, you won't be able to palpate above the lesion because it comes all the way down. Whereas a true scrotal swelling, you will be able to palpate above it. Just a good clinical point. Any questions? Any questions? If you do have, I won't be able to answer them. So please ask your Siri. Okay. Next question.
What is this?
What is this ECG showing? I wish I could zoom in. So first of all, what's this? What would you call that? ST elevation, right? ST elevation there, also here. So it's present in where? Everywhere, so all these. So we have diffuse ST elevation, which is pericarditis. But another thing is that, what else do they get in stage 1 of pericarditis? There's another sign that you need to look out for. They get PI depression. So if you look here, so remember, so this is the R wave likely there. This is the P wave. And what do you notice about that segment there? It's depressed, okay? So they don't necessarily have to have ST elevation. They can present with PI depression alone, and they can still be diagnosed with pericarditis depending on their clinical history. So just remember that. Don't be caught out, is all I'm trying to tell you. All right. And what's the management going to be for this patient? What else do we need to do? So just important management. NSAIDs is one. There's a few other things we need to do. So let's say, okay. So he needs to have an echo. Why does he need to have an echo? So you can have a pericardial infusion, okay? So pericardial infusion when he presents, and when does he also need to have an echo? 6 weeks later, okay? So he needs to have it at 0 hours, and he also needs to have it at 6 weeks. So he needs to have 2 to look for follow-up pericardial effusions to make sure that it's all resolved. Another thing is that I'll put another number 3 here. You can also consider troponins, because pericarditis can often mimic myocarditis, which is a much more serious pathology. So ECG and cardiac enzymes are also important. Okay, 76-year-old man, he has metastatic small lung carcinoma. First of all, before I go on, why have they included this in the question? Because this has a very low survival. Remember, this is like a 2% survival or something, maybe even less than that. So therefore, what is his management going to be? Palliative. In general? Palliative, okay? It's going to be apparent why I brought that up in a second. So he becomes increasingly confused and agitated in the evening. So what do we need to give him? Haloperidol, okay? So I've included that because where would you find this information? Read all of the palliative pages on ETG. I can't stress that enough. We had a lot of questions last year on palliative care. It's also very important. It pretty much always comes up, and ETG is really, really good for palliative care. And these, this might take you like, I don't know, 1 to 2 hours in total to read all of them. Probably not more than that. And it's also very good. So if you read the one about agitation, it tells you that the first line indication is haloperidol. Okay, so it doesn't tell. So we have to dig a bit more about why it's haloperidol. But what it tells us is that for a patient with agitation who has not been taking haloperidol or another antipsychotic drug, you can use halo as first line. Okay, but in other patients who have not been taking benzos, or if you consider it suitable, you can start them with clonazepam, so benzodiazepine. So it really depends on what's in the question, because also from EDG, if you have agitation that persists despite general measures, consider either benzo or haloperidol. So either may be tried first. So if clonazepam was in the question, you could also consider that as the answer. It really depends on what the other clinical history and potential contraindications are. And if one of them doesn't work, you can add a second drug. So you could do halo plus clonaz. Okay, so all of that information about all palliative care is on ETG. I mean, what have we done for palliative care? I mean, Gas gave a lecture. We talked about in one of our things about constipation and bowel obstruction, but there's many other pages that you should have a good read of. At the very least, note the medications. And just because we got played so hard in that region. Okay, we have a 48-year-old female. She has end-stage metastatic renal carcinoma. She has an itch, which has not been improved with the use of antihistamines. In this case, we would give her doxapen, okay? So doxapen is a TCA, is also first line according to some sources for pruritus, so we can use it in this situation. So again, we could have just used a sequence of ruling out other options. So aripiprazole is a atypical antipsychotic, diazepam, benzodiazepine, halo, is an antipsychotic, so one of our classic older generations. Olanzapine, atypical. Is it atypical? It's second gen.
Yeah, the
Like
My bad. Okay, antipsychotic. All the same. So zolpidem is sometimes used for sleep. Okay. All right. So, these questions. Okay. So we have a 30-year-old man who has troubling auditory and visual hallucinations. He's been treated with clozapine, and before we go on, treat him with clozapine, what does that imply already?
he's tried 2 others which haven't worked.
Yes, so he's likely got treatment-resistant schizophrenia, or he's tried 2 antipsychotics already, and they haven't worked. So that's important to pick up. Okay, so that's been going on for 12 months, and he's been experiencing disabling side effects on all other antipsychotics that he has tried. He gets a lot of benefit, but continues to experience some symptoms that cause him distress. What is the next most appropriate treatment? So for somebody who's already on clozapine, what treatment can we step up to? Is there any other treatment that we can use? So Kirby did a fantastic OSCE session on this, which I suggest all of you read. So adjunct as well as alternatives. So adjuncts, what are adjuncts for clozapine? So psychotherapy, okay? So somebody who has schizophrenia that is refractory to things like clozapine, you can use CBT. So CBT, the reason that it's used is because it's a targeted psychological treatment that can be used to control any of the residual positive symptoms or help the patient to effectively cope with those positive symptoms, which is why CBT is used. So as for alternatives, you can consider changing to another antipsychotic, but in his case, that's not going to work. So clozapine, so what you need to give him CBT. So CBT, one of the indications, especially in schizophrenia, is people who have treatment-resistant schizophrenia, it is shown to work. Okay, so as we often do, we are going to go through all of the most of the psychotherapies in this list. I think it's important. I think hopefully it will help you because psychotherapies is a very common topic. So we'll just try to go through it in an organized and systemic fashion. So we can break down psychotherapies into several broad umbrella categories and or terms. Okay, so one of them is psychotherapies that use classical conditioning. So classical conditioning, if you can remember, is your Pavlovian days, Pavlov's dog, where he used to give the dog the treat, he'd ring a bell, and the dog would start to salivate. So eventually the dog would start to salivate after hearing only the bell. So it's a learned response. So that's what classical conditioning is trying to reverse, or that's the reason we use it, because it's trying to reverse or change some kind of learned response. So the first one is systemic desensitization. So this is based on the fact that anxiety is caused by classical conditioning. So for example, I go on the train and I feel scared. So whenever I hear, for example, the sound of a train, I get scared, or any public transport causes me to be scared. So that is a classical condition. That's a learned response. You might have had one bad experience and you get scared forever. So systemic desensitization is used for that. I mean, this is fairly straightforward, but phobias and PTSD. Aversive therapy. So this is a bit different. So examples of this would be when you use things like naltrexone, or use disulfiram or camprosate for alcohol. So aversive therapy. So you pair a stimulus that evokes with something that evokes maladaptive behavior. So you give a medication to a patient who drinks a lot of alcohol, it causes them to feel terrible and vomit. So that's called aversive therapy. So 2 classical conditioning psychotherapies. Then psychodynamic psychotherapy. So the most important one is insight-oriented. So this is commonly what we see on TV and the movies, where the patient is sitting down on the couch and talking to the psychiatrist how you make the big bucks. So a patient talks to a clinician about what is on their mind, and the clinician looks for patterns in thinking that might explain the stress and anxiety. So essentially, what the goal or the aim of psychodynamic psychotherapies is to explore deep-rooted, unresolved issues and analyzing past to explain the present. That's a really important sentence. So I think Ian Presnell has harped on that point a few times, in that psychodynamic psychotherapy, so insight-oriented, is to analyze the past to explain the present. So particular things in your past, for example, trauma or abuse or something that was very terrible for that person, is now affecting how you function in your current life. So authority figures, relationship, etc. So all of the blue things that you see in these tables that are going to come are all previous formative exam questions and the answers that they were correlated with. So what we had a 30-year-old lawyer who's married, and she feels ambivalent about motherhood as she reflects upon her own adoption background. Okay, so she was adopted. She had some changes to her childhood experience, which is now affecting her current experience with how she's going to be as a mother. So the way that we can change that is by bringing out all of those emotions and past events and dealing with them. Okay, so that's why psychodynamic psychotherapy is used for that. And then cognitive psychotherapy. So there's at least 8 that we should know of. Okay, so first one is acceptance and commitment. So non-melancholic depression and anxiety. So I want to change, but something is stopping me from changing. So you want to change that but to an and. So you want to accept that you're scared of change, that you're accepting that, this is very difficult for me. I know I'm scared, but I'm still willing to overcome that. Whereas previous to this therapy, it would have been, I know that I can't do this, but I don't want to because I'm too scared. So changing that maladaptive behavior. So then interpersonal therapy, okay? So this one aims to improve the patient's interpersonal communication skills. So for example, we have a 30-year-old, so this is from a past exam question again. She had previously abusive partners and is depressed and having trouble in new relationships. So what the psychotherapist will do is look at what kind of interpersonal characteristics they have, so qualities within that person, and help them to change that. So an example of where this might be used is, for example, in someone with schizophrenia. So somebody with schizophrenia may have poor social skills and won't be able to interact with other people, so we could use interpersonal therapy there. So psychoeducation, very simply, improve health literacy, very important. So we have Fred, he's 56, second relapse of MDD, both being precipitated by him stopping his medication because he felt well. So obviously there, we know that when we counsel somebody with SSRIs, we have to tell them, don't stop it, you need to continue it. It takes a long time to work, you need to continue on it. So therefore, we need to educate him about his condition and how it's treated. So then the next 3, so supportive. So I wasn't really sure how to define it. So it's just a most common theory because it is generic. So it's just when you talk, for example, you go to see your psychologist rather than your psychiatrist, your psychologist, they will focus on you. They'll tell you about, relaxation techniques. They'll tell you about muscle relaxation, how to deal with things, deep breathing techniques. So essentially building defense mechanisms. So somebody who has some kind of problem, you support them in that area. So then the next one is DBT. So DBT, so specifically why it's used for borderline, is because it teaches the person emotional regulation, okay, and dialectical thinking. So I had to look up what dialectical meant, but it refers to somebody who has logical or discussion-based opinions and discussions. So somebody with BPD is often described as having black and white thinking. So they'll go and see their GP does a good job, they'll say, you're the best GP I have ever been to, hands down. So that is something considered black and white thinking because there's no middle ground. So you're trying to change that behavior and you're trying to form some dialectical and reasonable logical opinions, okay, rather than the black and white thinking that I talked about, and finding the middle ground. So that is why it's used for borderline, and specific for borderline. So then crisis intervention, the cognitive psychotherapy. So this usually refers to the CAT team coming out or the GP or somebody who deals with an acute issue, okay? So for example, in the previous question, we had a young man, he had a breakdown with his girlfriend, attempted suicide, and now he regrets it. So he's not acutely unwell, right? He's already attempted, so there's no reason to bring him into hospital. He regrets it, so he has some insight. So therefore, we can get the CAT team, who's still an acute team, to go and see him and make sure that he's okay. So post-impulsive event. So then mindfulness-based therapy. So you can sort of interchange this with motivational interviewing, so motivational. Okay, so this works on facilitate. So this definition is important. So facilitating and engaging intrinsic. Okay, so intrinsic means that it comes from within. Comes from within. So this means that the patient must have some form of wanting to change. That has to be present within the person to some degree. Okay, so you aim to move them through the stages of change. So for example, Prochaska declimated cycle, moving them through all of that, through that cycle. So to looking at a question, a 19-year-old, recurrent ED admissions with psychotic symptoms over 8 months. On several occasions, he's admitted to the acute psych ward and he's positive for drugs, amphetamines. He adamantly denies substance use, so that could mean that, for example, maybe he's guilty, potentially, he feels a little bit ashamed. His symptoms resolve, and on discharge, he's aware of having bad psychotic symptoms He understands the effects of amphetamines and says that this time he won't be back. So what would we do? We'd do motivational interviewing, and there's a reason why we wouldn't do something like group therapy. So going on to cognitive psychotherapies. So we've talked about this before. So this is trying to change so identifying a maladaptive cognition and changing that. So we won't go through that one. So then the last one is group psychotherapies. So self-help groups are things like your Alcoholics Anonymous, Gambling Anonymous, and Narcotics Anonymous, okay? There's no therapist. So specifically, what's important about this and how it differs from motivational interviewing is that the patient themselves must be seeking support. So in that previous question, what we saw is the patient did have the willingness and intrinsic ability to want to change, but they weren't actively looking for somebody to help them. They were adamant that they wouldn't come back. They weren't asking for a clinician to help them. So therefore, they need somebody, a clinician, or like a psychologist, psychiatrist, to move them through the stages of change, to then want to be able to seek support themselves. Okay, so then the final, so family-based, so eating disorders and then relationship counselor therapy are relatively self-explanatory. So this was what was in the question. So as we now know, the answer is motivational interviewing. So remember, these are faculty release questions as well. So the reason for that is because he's currently in one stage of change, okay? He might be in relapse, okay? Or he might be in pre-contemplation. Now, the reason we can say that is because he's adamant that he won't be back. So at the very least, he's thinking about ceasing amphetamines altogether, not using them in the future. So he is thinking about change. So he is in that cycle and we need to move him through. He's not seeking support, so therefore group therapy is not a reasonable answer. Does that make sense? Okay. All right, next question. So we have a 24-year-old. He's been receiving treatment with sertraline. 50 on. Also, for anybody who's bought a paper, you might notice that we're just jumping through some questions. We're not doing all of them. So a patient's been receiving sertraline 50 milligrams daily for 2 weeks. Okay, note that time is relatively short, following a 3-month history of worsening depression. He now presents with elevated mood, reduced need for sleep, and pressure of speech. What management should be undertaken first? So would we commence lithium? First of all, what do you think he's presenting with? Mania. Okay. Why is he presenting with mania? Mania or hypomania. Okay. So the thing is specifically for hypomania is you have to differentiate whether this causes enough functional impairment that they require admission to hospital and enough changes in their lives, which is not necessarily in this case, but he definitely, at the very least, is hypomanic. So this might be a manic arm of bipolar. Okay. So would you commence lithium? Anyone? What is your first line? Okay. Olanzapine? Okay. Stop sertraline?
No.
Why not?
I don't know, I was looking at the psychiatrist guidelines and they seem to say that you stop sertraline first, rebalance them, and then go from there.
Yeah, so I stop sertraline is the faculty answer, and it's the correct answer. Now, that's the reason I told you to look at the time period. So remember, if we're treating somebody with an antidepressant for depression, for example, major depression, it usually takes at least 4 to 6 weeks to come to effect, if not longer, okay? And after that period of time, when they're having a therapeutic effect from that, then they can get discontinuation symptoms if we stop it suddenly. But in this patient, because it's a very short time period, this is likely one of the phases of bipolar, okay? So it's just likely a precipitation of manic episode. So we've talked about it in a previous faculty release exam, in that we talked about how bipolar, especially in adolescents, can present for the first time in a manic and or depressive episode. So the sertraline that we're giving him in this situation is inducing that switch into mania or that rapid cycling. So he's initially depressed, now he's rapidly cycled into his manic period. So there still is a valid role for antidepressants in bipolar depression, as long as they are used in conjunction with appropriate prophylactic pharmacological therapy. So in this case, it's completely reasonable to stop sertraline. Does that make sense? So it's not like you're stopping sertraline in somebody who has MDD, in which case it'd be very different. But if you're serotonin syndrome, you'd also do the same. So I just want to highlight a few key points. And I tell you, right, looking through this took me down such a long rabbit hole, oh, you can't believe. Okay, first of all, so don't use antidepressants alone in the treatment of bipolar, but you can use it if they're on prevention, like we talked about. The second thing is that I've alluded to this before about the lithium station that we had last year. So there's a few psych medications that you should know really well and be able to explain if you ever get a counseling station. So, for example, clozapine, antidepressants, lithium, antipsychotics, you should be able to explain to a reasonable degree if you get an OSCE station. So last year we had a lithium counseling station, and one of the questions, or one of the things was a patient who was on lithium before, but now they had decreasing renal function. So what medication that you could change them to? So I assume nearly everybody says sodium valproate. Now, I've mentioned this to you guys before, but sodium valproate, read down here, is not approved by the TGA for use for the prophylaxis of bipolar disorder in Australia. Okay, so it is listed on ETG, and that is why it's such a rabbit hole, because it's so hard. It was very difficult for me to find definitive evidence and proof. So what I could find was that in 2000, no, that's for something different. That's for fluoxetine. Anyway, so it is listed on ETG for the management of people who are presenting with specifically depressive symptoms of bipolar. So you may as well go and read the article. But for people who have excessively depressive bipolar symptoms, you can use sodium valproate or you can use lamotrigine. So again, lamotrigine has not been used for the prophylaxis of bipolar. So what ETG is likely referring to is that, for example, let's say this patient didn't have the manic symptoms and he just had the worsening depression and he was already diagnosed with bipolar. Sodium valproate could probably be started in that situation. Do you understand what I mean? So in that situation, it's being used for the bipolar depression rather than for the prophylaxis of bipolar disorder. Do you understand the distinction I'm trying to make? Okay, but it's not used for the prophylaxis of bipolar, which is why a lot of people likely got, including me, probably did poorly on that station. So what would be the answer for a patient who's on lithium and needs to be changed to another medication for the prophylaxis of bipolar? Anybody? Yes, you can use the atypical antipsychotic. So all of them are pretty much first line, but at the top of the list is aripiprazole, and then you have things, aripiprazole, then different things. So, for example, so amisulpride, I think amisulpride is on the list, but at the very least, the top one is the one that I just mentioned, and that one doesn't cause any renal dysfunction. So that probably, I'm relatively certain that was the answer. So instead of changing him to sodium valproate, you would have changed him to a second generation antipsychotic, which is why it's always so important to always confirm information yourself, including me. So whatever I say, it's always important that you guys go look back and make sure that everything I'm saying is also valid. Because I said sodium valproate because I had just trusted other student notes and I hadn't actually looked at ETG myself, and I only learned this information this year, which is why I'm telling you now.
Wait, so last year's station was someone presenting with bipolar, and he didn't prophylaxis, not an acute episode.
No, so they had diagnosed bipolar.
Yeah.
They were now having decreasing renal function, so it might have been CKD, so you can't use lithium anymore. What medication are you going to change them to? Majority of students probably said valproate.
Yeah.
Whereas the better answer would have been something like aripiprazole. No question is silly, especially from you.
And wow, an antidepressant can set someone from bipolar over to mania. But how would you know that before, like if you treat a young kid with depression? Is it just like a check and see everything?
So I guess there's two clues in this step. Okay, the first one is the fact that you've only been treating him for 2 weeks, and it's very unlikely that depression would improve, especially worsening depression that's been going for 3 months would improve in that short period of time. The other thing is that the natural history for bipolar in adolescence is to present with that. And then the last thing is that sertraline or SSRIs can cause that rapid cycling. So normally to go from a depressive to a manic phase is months rather than weeks. So the fact that he's changed from 3 months of depression to now mania within 2 weeks is abnormal. It's not normal.
I get that, but like at the time of prescribing, how would you know that?
You wouldn't, which is why he was given sertraline in this question. So it's difficult. But now that we know, we'd stop that medication. Okay. Any other questions? Okay. Very good. Okay. So now we have a 17-year-old teenager. He's brought to his GP by his mum. Her mother describes that for several weeks, her daughter has been staying up late at night, acting erratically at home. Her friends have commented that she's spending an excessive amount of time on Facebook, posting repeatedly at all hours of the day and night. Sounds pretty normal. Still attending school, but is apparently very talkative and disruptive in class. What do you think she has?
Your everyday 17-year-old.
Hypermanic.
Yeah, I wish HIJ. Okay, I wish normal was here. No, so it is hypermanic. Okay, so to diagnose or to differentiate between hypomania and mania, both of them are essentially the same. Okay, all of them have the same features in them when you look at the DSM, with a few differentiating things. First is that for somebody to be diagnosed with a manic episode, it needs to be going on for more than 7 days. That does not mean that if they have the symptoms for more than 7 days, they can't still have hypomania. So please make sure that you understand that. So it can still be more than 7 days for someone with hypomania, but to be diagnosed with hypomania, it only needs to last for more than 4 days. Okay. So the other changes is that the biggest difference between hypomania and mania is that the change of function. Okay. So in somebody with mania, the change of function is sufficiently disturbed to cause a severe and marked impairment in the social or occupational functioning to necessitate hospitalization. So that's directly from DSM. Whereas in this case, she's still going to school, right? She's still going to school. She can still stay at home. So she doesn't have symptoms that is significantly functional impairment, which is why hypomania is the best answer. Okay, so now we have a 48-year-old with a history of schizophrenia and heavy alcohol consumption presents in a distressed state. Which symptom most strongly indicates the likelihood that he is experiencing acute alcohol withdrawal? Auditory hallucination, anyone? Option A? No. Okay. Option B? Not a command hallucination. Grandiose? No. Gustatory taste hallucination? No. Visual? Olfactory? Overvalued idea? Persecutory? Somatic? Yes. Okay. So somatic is usually in the form of something called formication, which we've talked about before. So formication with the M, not the N, and it's just the sensation of crawling on your skin. So there's actually a very small list of differentials that can give you tactile hallucinations. Okay. And of those things on that list, there is schizophrenia. So schizophrenia. There is Parkinson's disease. There's delirium tremens, and there is delusional parasitosis, which is also called Ekbom syndrome. Okay. The Ekbom syndrome is actually very interesting because I actually saw that myself as well. So when I was at Alfred, the one time that I went to derm clinic, there was a lady who came in and she was constantly scratching at her skin. And she kept describing the symptoms of feeling these ants crawling under her skin. And she had this little jar, like a makeup jar that was empty, filled with these little skin peelings and hair and scabs and stuff that she showed us, and she told look, this is the evidence. This is what I mean. So, actually, no, it wasn't as. She said she used to work as a dog hair washer, and she said that the hairs of the dog kept getting stuck under her skin, and that was causing all of her symptoms, and that's why she brought the little box with her. So then we talked to the consultant, and the consultant told us that is exactly how delusional parasitosis presents. So in the patient who has these tactile hallucinations, at the same time, they also bring in little something as evidence to show you that they are actually having these tactile hallucinations. Wow. And my mind was blown because she presented exactly like it is in the textbook, and it was so cool. So for things to give you tactile hallucinations, there's 4 things in common. So schizophrenia, Parkinson's disease, delirium tremens, which is again secondary to alcohol, and then delusional parasitosis or Ekbom syndrome. So these next few boxes are from Cecilia Zhu, who is still one of the 50s. I think she must have done a BMSI or something, but she taught me VESPA last year, and she had excellent slides, so I've included them here. Cecilia, I didn't ask your permission, but I hope you will forgive me, but I've given you credit here. So she makes such a great mnemonics. If you guys remember the mnemonics that we made for the roadmaps, like the same GCS and all that on that table in the Y files, that is all from Cecilia. She saved me so much for the psychoscopies. Okay, so intoxication syndromes are all pretty logical. So coordination, slow speech, unsteady gait. You might have nystagmus, impaired in the attention and memory. You might be hungover and you might pass out. Okay, in which case, if you do present to ED, what's going to happen? You want to do your acute assessment, so your A, B, C, D, E's. You want to do some electrolytes to make sure that it's not something else. So intoxication syndromes. So then the withdrawal symptoms, how do they present? Okay, so she uses synapathy, which is pretty cool. So for delirium tremens, I use another mnemonic, which I call death. Okay, so DE stands for delirium. Okay, A stands for autonomic, so autonomic hyperactivity / anxiety. Okay, T stands for tremor, that's usually cause, and then H stands for hallucinations. I just found it an easier one to remember. Okay, so delirium tremens or alcohol withdrawal syndrome So let me just rub that out. Also, so delirium. We'll just quickly talk about this because it's a good thing to know. So alcohol withdrawal syndrome. Okay. So this is the most severe manifestation of alcohol withdrawal. Okay. So usually occurs 72 to 96 hours post cessation. So after you stop drinking alcohol, which is why anybody who's going in for surgery who's an alcoholic needs to be prophylactically managed with diazepam. So what do you experience? You experience all these symptoms or the death mnemonic that I just talked to you about, and then it's rarely uncomplicated. So it always has some kind of complications with it because it is such a severe presentation. And the hallucinations that you get are usually tactile. Okay, so what do we need to give these patients? We need to give them diazepam, okay, which is on the list here. So it can be a very high dose. They might exceed more than 100 milligrams per day, depending on what they need. But what you don't want to do, so you start with per oral and you don't give them IV, okay? So if the per oral medication is not working, you don't step up to IV benzodiazepines because it has been shown to have no bigger difference to per oral benzodiazepines, okay? Instead, which is what is not on the list, you'd use something called droperidol, okay? So droperidol is also on the list if you look on prompt for acute behavioral disturbance, and you also use it for somebody who's presenting with delirium tremens if other medications are not working, specifically if they have psychotic symptoms, you might use it, okay? Psychotic symptoms, in which case you could also use things like halo or you could use benztropine. So benztropine is for in case they have EPSEs, so always consider that. And all of these medications, keep in mind, can all worsen hepatic encephalopathy, which somebody with delirium tremens might have, so keep that in mind as well. Okay, now maintenance. Now this is important. Now, this was another one that we got played on for the exam because we had like 5 questions on it and I was not prepared at all. Okay, so disulfiram. So all of these, most of these actually are used in Australia with the exception for disulfiram. Disulfiram is not that common, but it still is used, okay? So disulfiram, what that does is increases the symptoms of alcohol and increases the hangover symptoms that you get. So what happens is that disulfiram, it inhibits, so if we draw a picture of the liver, so it inhibits the aldehyde dehydrogenase enzyme, okay? So the aldehyde dehydrogenase enzyme, what that would usually be used for, dehydrogenase, is the conversion of acetaldehyde. So this is now going back to first year to aldehyde, to acetate, sorry. So what happens is that if we inhibit that, we have increased formation of acetaldehyde. So this increased concentration of acetaldehyde, it grows in the liver, and it's that what produces these unpleasant symptoms. So what symptoms do we get? We can get headaches, we can get nausea and vomiting, we can get dizziness, we can get vomiting especially, so that's a really big one. So essentially what it means is that it's just very, very unpleasant for the person whenever they drink alcohol. So that's why it acts as a deterrent. So things that you need to know for disulfiram is that the patient needs to be able to come back to see the doctor regularly. He needs to be supervised when he started, and they need to have friends and family involved because of all of these symptoms you can get. Imagine if you're vomiting uncontrollably and nobody's there to see you, you might have a bad time. So you need to have other people to monitor you while you're on that medication, just to make sure you don't die. So then the next one is acamprosate, which is more common. So this decreases the withdrawal symptoms that you get with alcohol. So how this works is that this modulates GABA in the brain, okay? So GABA and glutamate, So these are the neurotransmitters that are implicated in those withdrawal symptoms that you get from alcohol. So that's why it usually takes 1 to 2 weeks to work to reach the desired levels in the brain. And you need to maintain abstinence whilst you're on that medication. But sorry, it can also help with abstinence. And you need to wait 3 to 7 days after your first drink. Okay, both of these medications are used for 3 to 6 months. And then the last one is naltrexone. So this reduces the craving and pleasurable effects of alcohol, and it's used in pretty much every patient. So a question that we had on, must have been Avaya last year, was that what receptor does naltrexone act on? Does anybody know? So it was a mu opioid receptor. That's one of the questions. So it acts on that. So what acts on an opioid receptor? Dopamine. So therefore it decreases dopamine effects. We know dopamine is a pleasurable neurotransmitter. So therefore it can reduce the rate of relapse in heavy drinking and increases the number of abstinence days. And actually the number needed to treat was 7, which is not awesome, but it's also not bad. So maintenance therapy, what you need to know. Okay, next question. So we have a 36-year-old, according to A&E, with sudden onset, aggressive behavior, sexual disinhibition, and gait apraxia. Examination findings reveal old and new needle track marks on both his forearms. What do you think this is?
What drugs have you been taking?
So if you were reading this question, there's a reason that I've highlighted apraxia there. How many people, put your hands up, do you think would read that as ataxia? Anybody? So there's always the potential. So it's important to read the question carefully because apraxia is not the same as ataxia, okay? So apraxia, so if we compare, so apraxia is an inability, to perform, there are things that were previously familiar. So to perform previously familiar purposeful movements, okay? Whereas ataxia, okay, if we compare it, is they can carry out the movement, so it can do movement, but they don't have coordination, okay? So there's a very important difference there. So apraxia usually indicates some kind of frontal lobe symptoms or something that's happening in that situation. So there is a gait apraxia that's got a fancy name that is implicated in people who have bilateral frontal lobe disorders, which is inability to initiate the process of walking despite you having normal power and coordination. So apraxia is different from ataxia. So what do you think is going on here? The fact that he has old and new needle track arms indicates that he might be a candidate for something like endocarditis, maybe, okay? Or he might have some kind of abscess in his brain. So he might have had a septic emboli that's gone to his brain, could have had a stroke. He could have had a CNS infection. So stroke is probably less likely, but it's uncommon. I actually asked Risuri to give me some advice on this question. But the most importantly in this question, what you need to do is CT brain, okay? To rule out any kind of evolving intracranial pathology. You'd also want to do blood cultures because he might be septic. He might have had a septic emboli going to his brain. And echo going forward to look for that. So usually you need to do a TOE, so you need to do transesophageal echo, not a TTE, and you need to do cardiac monitoring ongoing. Does that make sense? So septic emboli likely. So a 19-year-old boy is found to be socially withdrawn with impaired motor coordination after attending a birthday party. He also appeared to be anxious, dry mouth, and red eyes. Bro, this guy's high as a kite, bro. He's been eating the devil's lettuce all day. So what has he got? Cannabis intoxication, that's correct. So he's just been smoking joint after joint. I was actually looking for good devil's lettuce memes, but I couldn't find one in time. Okay, so what we have here, we have a 20-year-old who's brought into hospital with complaints of experiencing strange voices, talking to him, threatening to harm him after a night out with his friends at a pub. He was found to be restless, pacing around aimlessly, perspiring and agitated. Fundoscopy reveals bilateral dilated pupils, and his symptoms subsided completely after a few days of admission. What do you think he has?
Meth-induced psychosis.
Yes, that's correct. Meth. So he has D. Okay. So not many drugs can. Well, so there are drugs, like many drugs do, but of the drugs that commonly cause a psychosis, amphetamines are one of the top ones. So this is from, I can't actually remember where this is from, but if we look at it, amphetamines, psychosis, okay? So LSD can give you visual hallucinations, which is not the same as psychosis. So in this case, he has a persecutory delusion, okay? Which is why it's important and why it's an important differentiator. So methamphetamine is the most likely one to give you those symptoms. I would highly recommend you go through this list or look at Cecilia's slides because she made lots of good mnemonic for it as well. I actually quite enjoyed this. So I was looking at RCGP, I was looking at street names for drugs, and I quite enjoyed that heroin is also called horse. Huh. Okay, next question. So Gabby, she's 30 years old, recently married, feeling ambivalent about, we did this question, so what was this? Insight, okay? So the past is the root of all present problems is a very common thing, so that's why we need to do insight. So Ahmed, 20 years old, 18-month history of schizophrenia, multiple admissions for worsening hallucinations. Since the onset of his illness, he has partial insight into his symptoms, since being tried on risperidone and more recently on quetiapine. Okay, so his symptoms improved with 2 antipsychotics, risperidone and quetiapine. However, he still has hallucinations. Finds them very distressing. He has a supportive family who monitors his medication compliance. He's otherwise well, aside from convulsions in childhood. So he's tried 2 antipsychotics. Therefore, what does he need? Clozapine. Okay. So again, I highly recommend that you go through the OSCE session that Kirby made because it explains everything you need to know about clozapine. Okay. Now, one thing is that I'll just point out, so febrile convulsions was in this stem. So it's probably just a distractor. Why do you think they've included it there?
You get seizures with clozapine.
Yeah, so clozapine can decrease your seizure threshold, and in some cases, it can be a relative contraindication to using clozapine unless you're already on some kind of anticonvulsant. But what happens is that, I mean, febrile convulsion does not increase your risk of epilepsy or seizures going on, so it's not something important in here. And again, like you said, you can use clozapine with seizures, but you just need to be on some medication. And another important thing that I want to point out, actually, is that when we're talking about common, intermediate, and serious side effects of medication, normally when we're looking for something like AMH defines a serious side effect as less than 0.1%, and a common side effect is more than 1%, okay? So the thing is that with clozapine, having the neutropenia, although we call it rare, is actually still common. It can happen in 1% of patients. This was from AMH itself. So it's from somewhere else that I looked. So neutropenia can happen in 1% of patients, which if we were looking at AMH and how they define it, it would have been considered a common side effect. Just an interesting thing.
I think it's 2%.
Is it 2% risk?
Yeah, and granular.
Yeah, so it's not necessarily rare. So it's not that rare. So instead of in a station calling it a rare side effect, you should say a serious side effect. Okay, so next one, we have Dave, he's 25. He's on the DSP. He's diagnosed with schizophrenia for a long time. Occasionally uses cannabis and smokes cigarettes. Okay, he has no social support, so no social support aside from these friends. So he always needs to see them, so you can't change that. Self-care is poor. His psychotic symptoms have responded well to quetiapine, risperidone, or olanzapine, so all three, okay? He was readmitted with psychotic symptoms due to poor compliance with his medication, and the team are planning discharge as his symptoms have again responded well to treatment, okay? So a patient who's responding well to treatment, but is not compliant, what do we need to give them? A depot, okay? So this question is asking us to choose which depot to use. So we have one, where we have risperidone and we have olanzapine. So how do I choose which one is correct? Why risperidone? Say again? No, okay, so that is not a reasonable argument because both of these can give you metabolic side effects. What you need to, so it's good that I'm telling you these today. So what you need to know is this list, okay? So these are drug interactions with smoking, which is why smoking was in the question and why I reiterate that point again. Always make sure that you try and understand why they've included each element in the question, okay? So in the previous question, the febrile convulsions was probably to throw you off, but it's still in there for a reason. Smoking here is also in there for a reason, okay? So there's a small list of medications that interact with people who are smoking. So I've highlighted the ones that you should know about. So clozapine, that's why in the clozapine station, you ask the patient, do you smoke? If you smoke, we have to manage that. Haloperidol, heparin is important, insulin, olanzapine, propranolol, tricyclics, benzos, and the OCP. So risperidone is not on this list. So what he's referring to is the fact that olanzapine, when you smoke, it induces the hepatic CYP, the cytochrome P450 pathway, and increases the breakdown, or sorry, increases the metabolism of olanzapine. So there's one study that found, I think, is it here? Well, somewhere. There was one thing that, or maybe it's on this list. Well, whatever I was reading, it was telling us that they did a study comparing people with olanzapine who smoked versus those who didn't smoke. And what they found, the people who smoked, they had only 84% of the total concentration that a person who didn't smoke had. So that is the reason we don't use olanzapine in this question, is because of smoking, not because of the metabolic side effects. Okay? There's no evidence to suggest that one depot antipsychotic is better than another depot antipsychotic. Okay? So it's only because of the smoking affecting the absorption profile. Does that make sense? So that's why risperidone is the answer. Is that acceptable? Okay. So please just, I mean, it's not too long of a list, so if you can just think about that list whenever you're in an exam or an OSCE. Okay. So Mary, 35, on dialysis with a history of schizophrenia, which has been well controlled on risperidone depot in the last 5 years. Previously been non-compliant in the 20s, but her psychotic symptoms have subsided on the depot and her lifestyle has been more stable. She has past history including admissions for suicide attempts. She's been admitted for a manic episode which has improved on risperidone, but now she appears to be getting depressed. So it's asking us for acute management, or at the very least management for bipolar depression. And what did we discuss we can use? Sodium valproate. So this is one of the things that took me down the rabbit hole, because like we said, it's not used in Australia. There's other medications that we can use. So if we look at another article about bipolar depression itself, it says that you can use quetiapine, okay? So quetiapine, I don't think is on this list. Oh, it is on this list. But the fact that she's already on an antipsychotic makes it a less reasonable answer. So there's just so many things to know. But sodium valproate, is reasonable.
How do you combine an SGA with an antidepressant?
Say again?
How do you combine a typical antipsychotic with an antidepressant?
Okay, but the thing is that because she's presenting with bipolar depression, the things that indicate in the situation are antipsychotics or sodium valproate, which is why valproate is the best answer.
So she's not an antipsychotic, so can't just give her an antidepressant.
You can only give her antidepressant if she's already being managed on prophylactic bipolar therapy. Remember, that's what we talked about? So because she's not already on prophylaxis, you can't start an antidepressant.
But would the antipsychotic act as prophylaxis?
Well, that is a good point.
Probably all mood stabilizers.
This is a rabbit hole. I don't know how to answer your question.
Valproate's a pretty dirty drug.
It is. Yeah, it is. I kind of disagree with this question, but that's all I can tell you is the facts. Okay, next. So Jane is 40. She has 2 young children. Husband has just been fired from his job. She has not been able to go to work because she's feeling anxious. So she's got anxiety. She's always been a worrier and now getting episodes of overwhelming fear. So she's got some panic symptoms. And she's now finally losing her mind. So definitely she's got, she's shaky and nauseous. She's got the systemic symptoms of panic. She feels like she may be having a heart attack. She's getting depressed and wants these symptoms to get better quickly so she can return to work. She doesn't want anything that will make her feel too dopey, so we can't give her benzos. So what would we give her? Escitalopram. So escitalopram is gold standard in anxiety. It's different to how you use it in depression in that it works faster. CBT is probably reasonable because it's not going to fix her acute symptoms, especially because she's presenting with panic type symptoms, and also she's a doctor, so she probably doesn't have time to go to CBT. Okay, so James is 14. He changed schools this year after his parents separated, has been finding it hard to settle in. He feels depressed, sleeping poorly for the last 3 months, previously being a B grade, but is now barely passing, does not seem to care. Friends in previous schools says he has not bothered to keep in touch or try to make new friends. So he sounds very depressed. So what would you start? What would you choose? What's another option? So I honestly think that there's 2 options here. I think CBT is also very, very reasonable for this. And I can't find definitive evidence for why fluoxetine is best. And the reason, this was actually the rabbit hole that I was talking about. I spent so long on this. So there's actually so if you go to ETG, it tells you that fluoxetine or SSRIs have not been approved by the TGA for the use in children under 16. There's a 2004 document released by the TGA explaining this, in that it tells you that SSRIs have an increased risk of suicide in people or in adolescents, which is why it has that relative contraindication. But that document further goes on to tell you that if you are concerned and if you believe that it's appropriate, you can still use the antidepressant, which is why it's still listed on ETG. That's why it's such a rabbit hole, because there's so many things. It says not approved, and it says you still can use it for this reason. So there's nothing definitive. There's no rules that I can give you. So the only thing in this question would be that the fact that he's got acute depressive symptoms right now. So as well as treating his depression with medication, you might consider CBT at the same time. But I guess in this setting, fluoxetine, medication that is long-term, less chance of withdrawal symptoms, is more reasonable in the adolescent population.
And escitalopram.
Well, you wouldn't use escitalopram in children, in adolescents. But that thing that I just told you, that has not been updated since 2004. So that's 14 years ago. And I couldn't find anything more. So I've got it up here. So this is from the ETG document. It says historical document in the watermark there. And it tells you that use of SSRIs should only be undertaken with the context of comprehensive management. So if they only need comprehensive management, which this patient might do because he does have some functional limitations. Now, again, the reason there is limited was because increased risk of suicide from some study. So Sandra, 35, just failed her exams for the second time. Studying for exams has caused her stress on her marriage and her libido is low. Lost weight, can't sleep. She feels nervous and tearful at work. She doesn't feel suicidal. So what medication would you use? Mirtazapine, okay? So mirtazapine, in this case, you're actually using the adverse effects of mirtazapine to treat her symptoms, okay? So you wouldn't use an SSRI, so you wouldn't use escitalopram because that is often can cause sexual dysfunction, and it can also cause in some people anorgasmia, which would further worsen her libido. And a lot of her symptoms might actually be related to the fact that her relationship with her partner is breaking down. So mirtazapine would increase that, it would help her sleep, and it would help her gain weight. So Zachary, 69, he is a lecturer who lives alone. He's a popular figure around campus, well known for his bow tie, dress sense, and high regard for punctuality. So his peers are concerned as he has not been turning up, so he's becoming more tardy. So maybe he's not getting good sleep, and it's been going for a long time. Appears disheveled when he turns up. Has lost weight, so maybe decreasing appetite. He seems to know his topics, so he hasn't lost any cognitive function, but his concentration is not as good as previously, and he's lost his interest in teaching, so he's a little bit anhedonic. He has not attended social staff functions, so maybe because he has less energy to go to parties, and he used to be the life of the party. So all of this indicates that he has MDT. So it's very, very unlikely that he has any kind of neurocognitive disorder because we talked about it, remember, you need to have some kind of derangement in one of those five cognitive domains that we talked about, which is not present in this question, as well as some kind of functional implication, which he does not have, but he is meeting nearly all of the criteria for same GCS, okay? So therefore, he has a major depressive disorder, potentially a pseudo dementia, some people might say. So not long left, nearly there. Rose is 67, long-standing back pain. She has osteo, a number of vertebral fractures. She gets incomplete benefit from analgesia and is now becoming depressed with anhedonia, decreased appetite, disturbed sleep, so she's definitely depressed. So what would you start her on? So which antidepressant would you use to treat both her back pain as well as her depression? Venlafaxine, so that's correct. So SNRIs, have been shown to have efficacy for people who have medical comorbidities because the thing is here is that she has neuropathic pain. Okay, that's what her back pain might be secondary to. And what happens is that in SNRI, the targets that it works on are both implicated in the hypothesis for the modulation of neuropathic pain, which is why venlafaxine and things like duloxetine are better and as efficacious for pain when added to gabapentin in some studies for neuropathic pain. So that's why venlafaxine and duloxetine are good for pain.
Sounds more like musculoskeletal.
Well, that's true. She has vertebral fractures, but the fact that she still has this ongoing pain is likely has a neuropathic component attached to it. Okay. Oh, this is. What condition is least likely to occur in anorexia nervosa?
Miscarriage.
Why?
Because they're not likely to get pregnant.
It's such a ridiculous. Yeah. So miscarriage. So it says severe. Okay. So severe. People severe are usually amenorrheic. Okay. So I guess the logic here is that somebody who's amenorrheic, who can't have a period, therefore can't get pregnant. Everything else can happen here. What's Russell's sign?
It's sort of scarring or callousing.
Yeah, so it's the scarring or change that you see on your knuckles for somebody who has bulimia, okay? Now, some people thought that was the answer, but that's not correct because you can still have a purgatory type of anorexia nervosa, so you might also get Russell's sign. Now, I honestly think this is a ridiculous question, and I feel like it was written by the same author who wrote this question on our exam last year, where they asked us which one is the least likely MSE finding for somebody with schizophrenia. And the important thing to know about this question is that it was removed from the exam because not a single person from the cohort got it correct. No one got it correct. 550 people and not one person was able to even correctly guess what the answer was. So I feel like maybe same author, who knows? Okay. We have a 35-year-old with schizophrenia for a long time, brought to see his GP. He lives in a rooming house. She is concerned about his compliance with medications and whether he is looking after himself. His room was filthy. He's not looking so moldy food, so poor personal ADLs. Very angry about coming in, says there is nothing wrong with him, poor insight. Mental state examination reveals delusional belief and other residents in the rooming house are plotting to have him killed. So he has some persecutory delusions. So he definitely has some deterioration in his community management of schizophrenia. So therefore, what do we need to do? Okay, so is there anything acute happening in this situation? Okay, so remember we talked about, is there somebody with deteriorating symptoms? You can get an assessment order, okay? So admit to hospital under the MHA. So that means either getting an assessment order or essentially admitting under the Mental Health Act as an involuntary inpatient because he has poor insight and he's deteriorating, so therefore he's at a risk to others. So getting a psychiatrist to see him and then getting him into the hospital. His GP is a medical practitioner, so the GP is allowed to make what's the AO stand for? Assessment order, and then the psychiatrist has to come and see him. So we talked about that extensively in one of our previous faculty release exams. So 32-year-old male with history of schizophrenia, reviewed in outpatients, has been stable on the olanzapine for 6 months, and on repeat review has presented with no evidence of any active psychotic symptoms. So that's important, okay? No evidence of any active psychotic symptoms. Describes a strong intention to severely hurt or kill his brother. Intent relates to several disparaging comments his brother has made towards him at several family events. So that's another important thing. So it's not secondary. So it's not secondary to psychotic symptoms, okay? So it's more likely to be like an emotional response, like an anger management problem. So in this case, what do you need to do? Alert the brother, okay? So some people might think that this might be called the police, but remember we talked about in the previous faculty exam, in what situations can you call the police? So if you think there's a genuine and immediate risk, okay? Immediate risk of injury to anyone. So his brother might be at risk, but there's no acute risk here, okay? It's secondary to not to psychosis, so therefore he has some control over his behavior. It's a threat that a lot of people make, and he has no active psychotic symptoms, so therefore the best thing to do in this situation is just to alert the brother and let him know what's been happening. This patient has not broken the law yet. Again, making threats. Actually, I don't know if it's breaking the law.
That's breaking the law.
Maybe it is. Okay.
Making that threats is illegal.
Next question. I'm gonna skip that question. Okay, so we have John. He's 30 years old. He's a married father of 2. He's brought to the ED. John has schizophrenia, managed by the same hospital as the ED. Passerby has, so that's the thing, they probably have access to his notes or there's some kind of medical history from him. He's been lying on the street bleeding profusely, okay, from an attempted amputation of his arm. So what major vessels are in the arm? You have, axillary artery that becomes your brachial artery, attached right to your subclavian. You could bleed very quickly from that. He needs surgery immediately, right now. Who is the first person responsible that can give consent? Is it relative?
No.
Remember, this is first, yeah. So there's no consent, okay? That's correct. Because this is an emergency situation. In any emergency situation where you think there's an acute threat to the life of someone, you don't need to get consent. So what on this list implies that you don't need consent? Hospital consultant, okay? So your hospital consultant is not consenting, he's just telling you that you can go ahead with this procedure. So that's what's happening in this situation. Emergency situation, very emergent, life-threatening, patient will die if you don't treat the symptoms now. Therefore, you don't need to get specific consent. So the best answer for this question would have been no consent required. I know I'm rushing a little bit because look, I really thought we'd finish on time today. Jackie is 45. She's living with her husband and teenage children. 1-year history of depression, which has not responded to antidepressant treatment. She is severely depressed and suicidal. Psychiatrist has advised her to have ECT. Her closest friend has advised her not to have it. Who is the main other person who should be involved in the discussion about her treatment? So remember that list we looked at from the Office of the Public Advocate. Who comes next in the list? Spouse. But even logically, the answer to this question is spouse. So the patient is already in this conversation. You would then ask the person who knows the patient best to give their opinion, which is the spouse. Nearly there. So Jane is 55. She's a divorced woman with multiple sclerosis, lives in her own house with a carer. She has multiple friends and relatives involved in her life, but no children of her own. She now needs assistance to manage her financial affairs. Who is the first person responsible that can assist her with this? So remember, going back to that list, in that list, what is first? A power of attorney, okay? Or somebody who's been appointed. So the answer here is an appointed enduring power of attorney. Okay, so 27-year-old man with anxiety presents to the GP admits to doctor shopping to obtain alprazolam. He's been taking 60 milligrams per day, which is a massive dose. That's very big. I'm pretty sure a normal dose is might be like 4 or 5 milligrams. He has not been able to secure a script and has begun to become panicky with paresthesia and twitching muscles. What is his most immediate risk? Seizures. So seizures is correct. Where is it? So seizures is correct. Okay. So some people might think that it might be drug withdrawal. Okay. But what's happening in this situation is that you have evidence of neuronal hyperexcitability. Okay. Excitability. The fact that he has twitching muscles. Okay. Twitching muscles. He has paresthesia. All indicate to you that his neurons are firing at a more higher rate. So he's at increased risk of having a seizure rather than getting drug withdrawal symptoms, which are systemic in nature. And he hasn't got systemic symptoms at the moment. So seizure is the most important thing at the moment. Okay, so say again?
Is that withdrawal or is that
drug withdrawal. So because he hasn't been able to secure the script, right? It says in the question, hasn't been able to secure the script, so it would have been a withdrawal condition. Okay, so we have a 21-year-old. She has vulval lesions. Okay, vulval lesions are secondary to HPV. What else can give you vulval lesions? That's dermatological. Lichen sclerosis. Okay, just consider it lichen sclerosis. So she's been engaging in the risk-taking behaviors following the breakup of a recent, brief but intense relationship with a same-sex partner. She reports often feeling impulsive and acting on these impulses when something upsets her. So what is the most immediate risk to the patient? What do you guys think? Huh? P, yeah, sexual risk. So the fact that she's got what might be an STI and that she has what sounds like regular partners indicates to you that she has a largest risk at the moment is a sexual risk or sexual in nature. That's the end.
Whoa.
So that was, I'm a bit lost for it. I'm not sure what to say. So that was the last slide for today. That was last faculty release exam. And before we finish, I wanted to give you the final tips. The final tips and tricks. These are just a few things that, there's not many. And I ran out of time to make a proper OSCE tips document. Maybe I might do in the future. But just some very quick things that I want to say. And also for what I've learned in life as well. Okay. So one thing is when you're in the OSCE, always think about what am I about to say? How many ways are there to say what I want to say? And which is the best way? So the best example, and I think some of you may have heard this from Kirby's revision session, but we were doing I was doing a clozapine station, and I was assessing a few students. And this is not to attack anyone, okay? But there was one student, when he was talking to the patient, he said, this patient needed clozapine. And he said, today we're going to start you on clozapine, or we're going to talk about the medication, which is clozapine. And then there was a different student who said, or meaning more or less, was like, I understand that you've come in with this schizophrenia that isn't working with any medication. And I know that can be very hard for you. I really think one of the best options for you is a medication called clozapine. And that's a discussion that I want to have with you today. So the point I'm trying to highlight is that there's a few differences in the style in both of those responses. So the first one is that the latter response is much more positive in its nature. It's inclusive of the patient, and it implies some shared decision-making, which is very important. OSCE examiners love that. But in general, that's also a very important concept itself. The other thing is that the student thought about what they wanted to say. They wanted to say, I want to start you on clozapine. But then they paused for a moment and thought about how many ways are there for me to express the fact that I want to start you on clozapine? And what is the best way? And the best way in that situation was that approach. So an even simpler example, this is something when I was on my GP placement, this is probably one of the only things I really enjoyed from my GP placement, was that I was talking to my GP and he said, how was your weekend or something like that? And I said, not too bad. Or he might have thanked me for something and I said, no worries. And then he sat me down for a moment and he told me, Taha, it's very often that people say no worries when you thank them for something. But actually the best way to respond is something like, you're welcome, or that's my pleasure. And the reason for that is when somebody thanks you, they aren't implying that they were ever worried about anything. So that when you then tell them their worries, it implies something negative. Like even though you're trying to give them something positive, there's some negativity in that you're implying that there was something to worry about and that you no longer have to worry about it. Whereas the whole interaction is supposed to be a positive thing. So what I'm trying to tell you in many words, and I wish I was more concise with what I'm trying to say, is that it's always good to try and be positive in what you say. Think about the kind of language that you're using. Think about how you're communicating with our patients. And I think other than OSCE, this is a very helpful tip for life. I personally try to do it myself. I'm not always good, but there's just something that I really appreciated my GP telling me. I didn't think it would make such an impact on me. So then what's another tip? Treat the actor like a patient. I think that's really important. I think the best students are people who understand the limitations of an OSCE and are still able to overcome that. So they understand that it's an actor in front of you, but despite that, they can still treat it as they would any patient that they saw on the wards. I think that's very important. So what I mean is that if this patient was in front of you, put yourself in their shoes. Think about what you're saying to them. So another good example was in that clozapine station, this patient, when you're commencing the medication, you need to give a brief period of 2 to 4 weeks of hospital admission, right? And some people just casually drop that. It's like, oh yeah, when we start, you need to come into hospital, it's all good, then we're going to do this and that. But if you think about it, this patient is going from home and suddenly they need to be in hospital for 2 to 4 weeks. That's nearly a month in time. It's not a small thing that you can just casually say to someone. So that's what I'm trying to tell you is that treat the actor like a patient. How would you feel if I told you, Dr. tomorrow you have to be in the hospital for 2 weeks? That's 2 weeks of your life. So just think about small things like that and how people would react to that situation. So treat the actor like a real person. I promise there's not too many tips. Okay, now if you are ever in your rest station, and I believe there's 2 and or 1 or 2, there's at least 1 plus minus another 1. So in the rest station, the best advice I can give you is that if you have a psych station coming up, write down all of your roadmaps mnemonic. So if you have a psych station, write down, like your name, age, occupation, past history of presenting complaint, then all of your mnemonics for depression, anxiety, mood disorders, psychosis. You see one of the slides in the YESPA document, in a mixtape of all of those mnemonics, and I think that's really helpful. The reason for that is because then you can straight go in a psych setting. You can spend the whole reading time just thinking about how you're going to approach the patient, and then just cross off as you're going through in that station itself. So it doesn't have to be the psych. It doesn't have to be a psych preparation, but just prepare for the station in advance. Use the rest station to rest, sure, but use at least some of the time to mentally and physically prepare yourself for the next station somehow. Okay. Is there any other tips? Yes.
I got told off by Jerry Vickers for writing in my.
Oh, are you not allowed to write?
Yeah.
Okay, be ready to write really quickly then. Okay, and okay.
Sorry, I have to go. I'm
It's
so
a-
sorry. We're going out for dinner.
Can I just give you something?
Like,
Yes, I do that.
thank you so
Bye.
much for everything you've done for us.
It's my pleasure,
for letting
Jess.
us pass.
It's my pleasure. And
Congratulations on finishing, guys.
thank you.
Be nice, pass it to everyone else's.
So the last OSCE tip I'll give you is be structured to an absolutely ridiculous extent. So going back to the clozapine station, for example, the examiner will be able to see that you're approaching it in a before, during, and after manner. So before clozapine, this is what we need to do. During clozapine, this is what we need to do. And after clozapine, this is what you need to do. If you're approaching a management station, you tell the patient there are 2 options that there are for your situation. I'm going to explain the first to you now, and there's 3 important things that you need to know about it. So just that level of structure is actually very helpful because it helps the examiner follow exactly what you're doing. So that's all I have for OSCE tips. If you just please permit me just 2 or 3 minutes, I just want to express how I'm feeling at the moment. Just my last words, I swear, it won't take long. It might take long, I don't know. So just my last words. And when I was writing it, I didn't know what to write, to be honest. There was one thing actually. So just when I was preparing for today's session, I was on the mixtape because that's how I prepare for it. And usually there's nobody else on the document at the same time. But then I just came on one day and there was just so many people using the document out of nowhere. I was just completely taken aback and shocked. And I think what I'm trying to express is that it just made me so happy in that moment. Not because somebody's using my resources, but the fact that even in my own small way, I could have whatever small impact, on your journey through medicine. Because truly, something that Michelle Leach said today in our last session is that teaching, at least for some people, is just such a pleasure. It just can give you so much happiness in your life. It's very hard to express in words. I'm becoming a bit emotional now, but it's just something that you can enjoy so much. And just seeing that at that time, it just made me so, I'm sorry, it just made me so happy. I'm sorry. It's a bit ridiculous.
No, it's not.
I'm very sorry.
I'm tearing up as well.
So I'm very happy that I was able to.
All right, round of applause for Taha, guys. He's done an amazing job for you guys this year. And yeah, well, I mean, Kirby started it all and everything, but Taha really has taken you guys since the start of this year. And there's no need to lie. He's had us for help, but it's been very minimal. He's done most of it himself. And I think the OneNote initiative is something that that was all him throughout med school. He is 1 to 4. And yeah, I think you guys are very lucky to have known this man, and I would recommend keeping in touch with him because he's going to go far in life. Yeah, and I'm sure he'll come out of his way next year if you have questions about job applications or general life tips. He's always someone with time.